by NewsFirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, knowledge partner Vyli Health. Well, we're talking about path to parenthood, and did you know that India's surrogacy laws have evolved significantly? In the past few years, I think there is surety on protection for all the parties that are involved. So the next panel discussion is going to be on the topic donors, surrogacy, and legal framework surrounding these sensitive topics. And I want to welcome our beloved panelists on the stage. Let us all put our hands together and welcome Dr. M.S. Srinivas, Director and Principal Embryologist, Carey Fertility Private Limited, onto the stage. Can we all give a huge round of applause, ladies and gentlemen? We are going to talk about donors, surrogacy, and the legal framework. And we have with us Dr. M.S. Srinivas, Director and Principal Embryologist, Carey Fertility Private Limited. I also would love to welcome Dr. Bharati Rajanna, Medical Advisor, Apollo Cradle and Children Hospitals. A warm welcome to you on the dais, ma'am. I'm sure this is going to be a very informative session. And to moderate this session, we have senior journalist Archana Ravikumar. Can we all give a huge round of applause and acknowledge Archana Ravikumar ma'am's presence? So, over to you, team.
Hello?
Hello?
Good afternoon, everyone. Good afternoon, everyone. Now we'll be talking about beyond fertility regarding donors and surrogacy. From yesterday, we've been hearing about egg and sperm. So this is more about that. So today I'll start my question with Dr. Bharati Rajanna. So what is the role of egg and sperm donor in fertility treatments, doctor?
Hello, good afternoon, everyone.
I think.
Hello. Good afternoon, everyone. After a lunch, I suppose you won't have a nap now. Okay? She asked me, what is the role of egg and sperms? Before that, I will just, of donors the two. Before that, just I will brief you regarding the ICMR guidelines. ICMR, that is the Indian Council of Medical Association, Apex in Delhi, okay, where they formulate the guidelines. So we all follow these guidelines, okay, that is the art clinic. Please, can you repeat the question?
The role of egg and sperm donors.
Yeah. Now, I will be telling you what are the roles. The role of a donor is to donate the eggs and the sperm too. But when do we select is very important. That has been formulated by ICMR, sorry. Okay, a girl below 21 years cannot take any donor eggs or the sperms. And a married couple are eligible to take. And that too, a married couple staying together for 2 years can take these donor sperms and donor eggs. Okay? And this is recommended. It is not a commodity, right? So it has to be approved by the medical personnel. And the idea behind that is they cannot produce egg quality one or a quantity one. And that is the reason where we go for the donor eggs and for the donor sperms. So the main guidelines which we follow is, if a woman is at the end of the reproductive age, that is round about 40, 42, where they cannot produce healthy and quality sperms, then they are offered this. Or if they have a premature ovarian failure, that is if they attain menopause before the age of 40. Apart from this, if a woman is suffering from any of the health conditions, like any genetic conditions, the sexual chromosome conditions which are transferred in the family, and she won't be having any live baby, they are recommended. And also we have to remember, nowadays cancer are booming so much and the young girls are having cancers. So a cancer treatment patient or who have undergone chemotherapy, radiotherapy, they are all offered the donor eggs. And coming to the males, okay, and I want to tell you here one thing, even if a woman, a single woman can take a donor sperm and have a baby, okay. And coming to the men, it is the quality which is important. Quality, that is the quality or the quantity, it is not a concern. Only the morphology and motility of the sperm, if it is too low and if there are failed IVF cycles, then they can opt for the donor sperms. And even the male who have undergone any radiation, chemotherapy, not suitable sperms, azoospermia, which is very important nowadays. But nowadays we have advanced so much that even with azoospermia, we do TISA, we collect the sperms. But sometimes there is testicular condition where FSH, LH, they are resistant to the Sertoli cells, the Sertoli cell syndrome, where cannot get the sperms or a good quality, or where we will be transmitting the diseases from the X and Y chromosomes. That is, we call it as autosomal recessive, autosomal dominant conditions. Common ones in our country which we have seen is thalassemia, hemophilia, dystrophy, okay, dystrophy, and many of the conditions, neurofibromatosis, okay, and metabolic disorders. We select the sperms by doing the genetic testing for the donors and for the males, and then we choose the sperms. So they play a very vital role in formulating the family, that is giving a hope for childless couple. Isn't it great?
Yes, yes, definitely, doctor.
ಮೊದಲಿಗೆ ಫಸ್ಟ್ ನ್ಯೂಸ್ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮನ ಹಮ್ಮಿಕೊಂಡು ನನ್ನನ್ನು ಇನ್ವೈಟ್ ಮಾಡಿರ್ತಾರೆ. ಅವರಿಗೆ ಕ್ಯಾರಿ ಫರ್ಟಿಲಿಟಿ ಪ್ರೈವೇಟ್ ಲಿಮಿಟೆಡಿಂದ ಕೃತಜ್ಞತೆಗಳು. ಇದು ಒಂದು ಒಳ್ಳೆಯ ಪ್ರಯೋಗ. ಇದುವರೆಗೆ ಈ ಥರದ ಕಾರ್ಯಕ್ರಮಗಳು ನ್ಯೂಸ್ ಚಾನಲಿಂದ ಆಗಿರಲಿಲ್ಲ. ಇವತ್ತು ಫಸ್ಟ್ ನ್ಯೂಸು ಚಾನಲ್ಲು ಹಮ್ಮಿಕೊಂಡಿದೆ. ನಿಮಗೆಲ್ಲ ತಿಳಿದಿರೋ ಹಾಗೆ ಬಂಜೆತನ ಅನ್ನೋದು ಒಂದು ಸೋಷಿಯಲ್ ಸ್ಟಿಗ್ಮಾ ಅಂತ ಹೇಳ್ತೀವಿ. ಈ ಒಂದು ನಿವಾರಣೆಗೆ ಸತತವಾಗಿ 40 ವರ್ಷಗಳಿಂದ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಗಳನ್ನು ಅಸಿಸ್ಟೆಡ್ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಟೆಕ್ನಾಲಜಿಯಿಂದ ಹಮ್ಮಿಕೊಂಡು ಬಂದಿದೆ. ಇದರಲ್ಲಿ ಹಲವಾರು ಪ್ರಯತ್ನಗಳನ್ನು ಮಾಡಿ, ಸಂಶೋಧನೆಯನ್ನು ಮಾಡಿ, ಇವತ್ತು ನಾವು ಬಂಜೆತನ ನಿವಾರಣೆಗೆ ಅತ್ಯಮೂಲ್ಯವಾದ ಕೆಲಸವನ್ನು ಮಾಡಿ ಒಳ್ಳೆ ಸಕ್ಸಸ್ ರೇಟನ್ನು ತಂದು ಕೊಡ್ತಾ ಇದ್ದೀವಿ. ನಾನು ಈ ಒಂದು ಫೀಲ್ಡ್ನಲ್ಲಿ ಸುಮಾರು 30 ವರ್ಷದಿಂದ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ದೇನೆ. ನಾನು ಭ್ರೂಣತಜ್ಞನಾಗಿ 30 ವರ್ಷದಿಂದ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಇದ್ದು, ನಾನು ಮೊದಲನೇ ದಿನದಿಂದನೂ ನಿಮಗೆ ಹೇಳಬೇಕು ಅಂತಂದರೆ ಇಷ್ಟು ಅವೇರ್ನೆಸ್ಸು ಇರ್ತಿರಲಿಲ್ಲ. ಬಂಜೆತನ ಅಂತಂದರೆ ಮದುವೆ ಆದ ಮೇಲೆ ಅವರು ಸುಮಾರು 1-2 ವರ್ಷ ಕಾಯ್ತಾಯಿದ್ರು. ತದನಂತರ ಟೆಂಪಲ್ಗೆ ಹೋಗೋದು, ಆಯುರ್ವೇದ, ಈ ಥರದ ಟ್ರೀಟ್ಮೆಂಟ್ಗಳು ನಡೀತಿದ್ವು. ಇದನ್ನೆಲ್ಲ ಆಗಿ ಅದಾದ ಮೇಲೆ ಇನ್ನೂ ನಮಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಲಿಲ್ಲ, ನಮಗೆ ಮಗು ಬೇಕು ಅಂದಾಗ ಮಾತ್ರ ಅವರು ಈ ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟ್ಗೆ ಸೆಂಟರ್ಗೆ ಹೋಗ್ತಾಯಿದ್ರು. ಇವತ್ತು ಆ ಥರ ಇಲ್ಲ. ಈ ನ್ಯೂಸ್ ಚಾನೆಲ್ಗಳಿಂದ ಇರೋದರಿಂದ ಅವೇರ್ನೆಸ್ಸು ತುಂಬ ಇದೆ. ನಮ್ಮ ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟರ್ಗೆ ಅಪ್ರೋಚ್ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಅವ್ರಿಗೆ ಬಂಜೆತನ ನಿವಾರಣೆ ಮಾಡೋದ್ರಲ್ಲಿ ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟರ್ಗಳು ಪ್ರಯತ್ನ ಮಾಡಿ ಅವ್ರಿಗೆ ಒಳ್ಳೆಯ ಸಕ್ಸಸ್ ರೇಟ್ ಕೊಡ್ತಾ ಇದ್ದಾರೆ. ಮತ್ತು ಮೇಡಮ್ನವ್ರು ಹೇಳ್ತಾ ಇದ್ರು ಒಂದು 2-3 ಪಾಯಿಂಟನ್ನ ನಾನು ಆ್ಯಡ್ ಮಾಡಲು ಇಚ್ಛೆ ಪಡ್ತೇನೆ. ಏನೇ ಒಂದು ನಾವು ಸಂಸ್ಥೆಯಲ್ಲಿ ಕೆಲಸ ಮಾಡಬೇಕು, ಒಂದು ಗೈಡ್ಲೈನ್ಸ್ ಅಂತ ಇರ್ತದೆ, ಒಂದು ರೂಲ್ಸ್ ಆ್ಯಂಡ್ ರೆಗ್ಯುಲೇಷನ್ ಅಂತದೆ. ವೆದರ್ ಅದು ಹೆಲ್ತ್ ಸೆಕ್ಟ್ರಲ್ಲಾರೆ ಇರ್ಬೋದು, ಯಾವುದು ನರ್ಸಿಂಗ್ ಹೋಮ್ನಲ್ಲಾರೆ ಇರ್ಬೋದು, ಹಾಸ್ಪಿಟಲ್ಲಾಗಿರ್ಬೋದು. ಈ ಒಂದು ಸಂಸ್ಥೆ, ಈ ಒಂದು ಇನ್ಫರ್ಟಿಲಿಟಿಗೆ ಗೈಡ್ಲೈನ್ ಅನ್ನೋದು ಇರಲಿಲ್ಲ, ರೂಲ್ಸ್ ಆ್ಯಂಡ್ ರೆಗ್ಯುಲೇಷನ್ ಅನ್ನೂ ಇರೋದಿಲ್ಲ. ಮತ್ತು ಇದು ಏನು ಅಂತಂದರೆ, ಈ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟು ಗೌರ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿನಲ್ಲಿ ಇರಲಿಲ್ಲ. ಈಗ ಕ್ರಮೇಣವಾಗಿ ಇದು ಗೌರ್ಮೆಂಟ್ ಫೆಸಿಲಿಟಿನಲ್ಲಿ ಬರ್ತಾ ಇದೆ. ಹಾಗಾಗಿ ಪೂರ್ ಕಪಲ್ ಆಲ್ಸೋ ಇವತ್ತು ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟನ್ನ ತಗೋಬೋದು. ಯಾಕೆಂದರೆ ಇನ್ಫರ್ಟಿಲಿಟಿ ಟ್ರೀಟ್ಮೆಂಟ್ ಅನ್ನೋದು ತುಂಬ ಎಕ್ಸ್ಪೆನ್ಸಿವ್ ಅಂತಂದರೆ ಅದು ಖಂಡಿತ ಕಾರ್ಪೊರೇಟ್ ಸೆಕ್ಟರ್ಗೆ ಹೋಗ್ತಾರೆ. ಏಕೆಂತಂದರೆ ಅವ್ರಿಗೆ ಒಳ್ಳೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಬೇಕಾಗ್ತದೆ. ಕೆಲವು ಟೈಮು ಸ್ಟ್ಯಾಂಡ್ ಅಲೋನ್ ಸೆಂಟರ್ಗೆ ಹೋಗ್ತಾರೆ. ಈ ಥರದಲ್ಲಿ ಹೋದಾಗ ಅವ್ರಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕಾಸ್ಟು ವೇರಿ ಆಗ್ತದೆ. ಗೈಡ್ಲೈನ್ಗೆ ಬಂದಾಗ ಮೊದಲು ನಮ್ಮದು ಗೈಡ್ಲೈನ್ ಅಂತ ಇದ್ದು, ನಾನು ಕೂಡ ಅದರಲ್ಲಿ ಒಬ್ಬ ಎಕ್ಸ್ಪರ್ಟ್ ಕಮಿಟಿ ಮೆಂಬರ್ ಆಗಿದ್ದೆ. ತದನಂತರ ಇದು ಸೆಂಟ್ರಲ್ ಗೌರ್ಮೆಂಟ್ಗೆ ಹೋಗಿ ಅವರು ART ರೂಲ್ ಮತ್ತು ಸರಗಸಿ ಕಾನೂನು ಅಂತ ಮಾಡಿ 2022ರಲ್ಲಿ ಇದಾಯಿತು. ಇದಾದ ನಂತರ ಯಾವುದೇ ಸೆಂಟರ್ಗಳು IVF ಮಾಡಬೇಕು ಅಂತಂತಂದರೆ ಪರ್ಮಿಷನ್ ತೊಗೊಬೇಕಾಗುತ್ತೆ, ಲೈಸೆನ್ಸ್ ತೊಗೊಳ್ಬೇಕಾಗುತ್ತದೆ, ಅದರದ್ದೇ ಆದಂಥ ಕಾನೂನು ಇರ್ತದೆ. ಕಾನೂನನ್ನ ಪಾಲಿಸ್ಕೊಂಡು ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡೋದು. ಯಾಕೆಂದರೆ ಈ ಒಂದು ಸಂಸ್ಥೆಯನ್ನು ಮಾಡಬೇಕಾದ್ರೆ ಮ್ಯಾಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಆಗ್ತದೆ, ಇದನ್ನು ರೆಗ್ಯುಲೇಟ್ ಮಾಡಬೇಕಾಗುತ್ತದೆ ಅಂತಂತ ಹೇಳ್ಬಿಟ್ಟು ಗೌರ್ಮೆಂಟು ಮುಂದೆ ಬಂದು ಇದನ್ನು ಮಾಡಿರುತ್ತೆ. ಯಾಕಂದರೆ ಇದನ್ನು ನಾವು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಅಂತೀವಿ. ದಾನಿ ವೀರ್ಯಾಣು, ದಾನಿ ಅಂಡಾಶಯ ಅಂತಂದರೆ ಮೊಟ್ಟೆ ಒಂದು ಫೀಮೇಲ್ನಲ್ಲಿ ಇಲ್ಲ ಅಂತಂತಂದರೆ, ಅಥವಾ ವೀರ್ಯಾಣುಗಳು ಸರಿಯಾಗಿ ಪ್ರೊಡಕ್ಷನ್ ಆಗಲಿಲ್ಲ ಅಂತಂದರೆ ಮೇಲ್ನಲ್ಲಿ ಯಾವ ಥರದವಾಗಿ ನಾವು ಅದನ್ನು ಡಯಾಗ್ನೋಸ್ ಮಾಡಬೇಕು, ಯಾವ ಥರವಾಗಿ ಅದನ್ನು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕು ಅನ್ನೋದನ್ನು ಅದು ಅತ್ಯಾಧುನಿಕ ಟ್ರೀಟ್ಮೆಂಟಿಂದ ನಾವು ಅದನ್ನು ಸಾರ್ಟ್ ಔಟ್ ಮಾಡ್ಬೋದು. ಇವತ್ತು ಏನು ಟೆಸ್ಟಿಕಲ್ ಇಂದ ಸ್ಪಮ್ನ ರಿಟ್ರೀವ್ ಮಾಡ್ಬೋದು, ಎಗ್ಗು ಅಂಡಾಶಯದಲ್ಲಿ ಇಲ್ಲ ಅಂತಂದರೂ ಅಂಡಾಶಯದಲ್ಲಿ ಎಗ್ಗು ಬರೋಗೆ ಮಾಡ್ಬೋದು. ಇದೆಲ್ಲ ಆದ್ರೂ ಕೂಡ ಮುಂದೆ ಸಂಶೋಧನೆ ಆಗುತ್ತಾ ಅದೇ ಒಂದು ಫೀಮೇಲ್ ಅದೇ ಒಂದು ಮೇಲ್ನ ಸಂಬಂಧಪಟ್ಟಂತೆ ಸ್ಪರ್ಮು ಅಂದರೆ ಏನು ವೀರ್ಯಾಣು, ಮೊಟ್ಟೆ, ಎಗ್ ಅನ್ನೋದನ್ನು ಮಾಡಬೇಕು ಅಂತ ಮಾಡೋ ಪರಿಸ್ಥಿತಿಗೆ ನಾವು ಬಂದಿದ್ದೀವಿ. ಹೀಗಾಗಿ ಅವರಿಗೆ ನಾವು ಈ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟಿನ ಅತಿ ಶೀಘ್ರವಾಗಿ ಅತಿ ಕಡಿಮೆ ಖರ್ಚಿನಲ್ಲಿ ಮಾಡ್ಬೋದು ಅಂತ ನಾನು ಹೇಳಲು ಇಚ್ಛೆಪಡ್ತೇನೆ.
ಥ್ಯಾಂಕ್ ಯು ಡಾಕ್ಟರ್ ಫಾರ್ ದ ಎನ್ಲೈಟ್ಮೆಂಟ್. ಈಗ ನೀವು ಸೈಂಟಿಫಿಕ್ ಆಗಿ ಎಕ್ಸ್ಪ್ರೆಸ್ ಮಾಡೋದಾದರೆ ಹೇಗೆ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡ್ತೀರಾ ಡಾಕ್ಟರ್ ಎಗ್ ಆ್ಯಂಡ್ ಸ್ಪರ್ಮ್ ಡೋನರ್ ಬಗ್ಗೆ?
ನೋಡಿ, ಯಾವುದೇ ಒಂದು ಕಪಲು, ಬಂಜೆತನ ಇರುವಂಥ ಕಪಲು ಯಾವುದೇ ಒಂದು ಇನ್ಫರ್ಟಿಲಿಟಿ ಸೆಂಟ್ರಿಗೆ ಹೋದಾಗ ನಾವು ಬೋತ್ ಮೇಲ್ ಆ್ಯಂಡ್ ಫೀಮೇಲ್ಗೆ ಡಯಾಗ್ನೋಸ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಡಯಾಗ್ನೋಸ್ ಮಾಡಿದಾಗ ನಮಗೆ ಗೊತ್ತಾಗ್ತದೆ. ಕ್ಲಿನಿಷಿಯನ್ಸು ಅದನ್ನು ಯಾವುದೇ ಸಿಮೆನ್ ಅನಾಲಿಸಿಸ್ ರಿಪೋರ್ಟಿಂದ ಸ್ಕ್ಯಾನಿಂಗ್ ಮಾಡಿದಾಗ ಅವ್ರಿಗೆ ಗೊತ್ತಾಗ್ತದೆ ಅವರು ಎಷ್ಟು ಏಜ್ ಇದೆ, ಏನು ಹಿಸ್ಟ್ರಿ ಇದೆ, ಯಾವ ಥರವಾದ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಟ್ಟರೆ ನಾವು ಅವರಿಗೆ ಬಂಜೆತನ ನಿವಾರಣೆ ಮಾಡ್ಬೋದು ಅಂತ ಹೇಳ್ತೇವೆ. ಮೊದಲಿಗೆ ಇಂಟ್ರಾಯುಟ್ರೈನ್ಸ್ ಇನ್ಸೆಮಿನೇಷನ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಅಲ್ಲಿ ಫೀಮೇಲ್ಗೆ ಏನೂ ತೊಂದರೆ ಇಲ್ಲ, ಅವ್ರಿಗೆ ಮುಟ್ಟು ಸರಿಯಾಗ್ತಾ ಇದೆ, ಮೊಟ್ಟೆಗಳು ಸರಿಯಾಗಿ ಉತ್ಪತ್ತಿ ಆಗ್ತಾ ಇದೆ, ಓನ್ಲಿ ಮೇಲ್ ಫ್ಯಾಕ್ಟ್ರಿ ಇದೆ ಅಂತಂದರೆ ವೀರ್ಯಾಣುವಿನಲ್ಲಿ ಚಲನವಲನಗಳು ಸರಿಯಾಗಿಲ್ಲ, ಮೋಟಿಲಿಟಿ ಸರಿಯಾಗಿಲ್ಲ, ಅದರ ಕ್ವಾಂಟಿಟಿ ಸರಿಯಾಗಿಲ್ಲ ಅಂದಾಗ ಅದನ್ನು ಹೆಚ್ಚಿಗೆ ಮಾಡಿ ಈ ಒಂದು ಪ್ರೊಸೀಜರಿಂದ ಅವ್ರಿಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಹೇಗೆ ಕೊಡ್ಬೋದು ಅಂತ ಪ್ರಯತ್ನ ಒಂದು ಹಂತದಲ್ಲಿ ಮಾಡ್ತೀವಿ. 1-2 ಸೈಕಲು ಈ ಥರ ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಿದಾಗ ಅವ್ರಿಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಿಲ್ಲ ಅಂದ ಮಾತ್ರಕ್ಕೆ ಪ್ರಣಾಳ ಶಿಶು ಅಂತ ಹೇಳ್ತೀವಿ ನಾವು, IVF ಅಂತ ಹೇಳ್ಬಿಟ್ಟು. ಈ ಒಂದು ಪ್ರೊಸೀಜರ್ನಲ್ಲಿ ಯಾಕಂದರೆ ಒಂದು ಋತುವಿನಲ್ಲಿ ಒಂದು ಫೀಮೇಲು ಒಂದೇ ಎಗ್ನ ರಿಲೀಸ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಮಾಡೋದು ನಾವು ಈ ಒಂದು ಪ್ರಣಾಳ ಶಿಶು ಪ್ರೊಸೀಜರ್ ಮಾಡಬೇಕಾದ್ರೆ ಅವ್ರಿಗೆ ಹಾರ್ಮೋನ್ನ ಕೊಟ್ಟು ಅತಿ ಹೆಚ್ಚು ಮೊಟ್ಟೆಗಳನ್ನು ಬರೋಂಗೆ ಮಾಡ್ತೀವಿ. ಯಾಕಂದರೆ ಈಗ ನಮ್ಮ ಗೈಡ್ಲೈನ್ನಲ್ಲಿ 7 ಎಗ್ಗು ಮಾತ್ರ ರಿಟ್ರೀವ್ ಮಾಡಬೇಕು ಅಂತ ಇದೆ. ಹಾಗಾಗಿ ಯಾಕೆಂತಂದರೆ ನಾವು ಏನೇ ಒಂದು ಟ್ರೀಟ್ಮೆಂಟ್ ಮಾಡಬೇಕಾದ್ರೆ ಆ ಫೀಮೇಲ್ನ ಆರೋಗ್ಯ ತುಂಬ ಇಂಪಾರ್ಟೆಂಟ್ ಇರ್ತದೆ. ಹಾಗಾಗಿ ಅವರು ಹೈಪರ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ಗೆ ಹೋಗಬಾರ್ದು ಅಂತೇಳಿ ಅತಿ ಮೈಲ್ಡ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ ಮಾಡಿ ಅವರಿಗೆ, ಯಾಕಂದರೆ ಈ ಹಾರ್ಮೋನ್ ಕೊಡೋದ್ರಿಂದ ಅವ್ರಿಗೆ ಆರೋಗ್ಯಕ್ಕೆ ತೊಂದರೆ ಇರುತ್ತೆ ಅಂತಲೂ ರಿಪೋರ್ಟ್ಸ್ಗಳು ಇರೋದ್ರಿಂದ ಪದೇ ಪದೇ ಕೊಡೋದ್ರಿಂದ ನಾವು ಅವ್ರಿಗೆ ಮೈಲ್ಡ್ ಸ್ಟಿಮ್ಯುಲೇಷನ್ ಮಾಡಿ 7 ಎಗ್ಗು ಬರೋಂಗೆ ಅಥವಾ ಬಂದರೂ ಪರವಾಗಿಲ್ಲ 1-2-3 ಹೆಚ್ಚು ಆ ಒಂದು ಮೊಟ್ಟೆಗಳನ್ನು ನಾವು ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟ್ ಅಂತ ಹೇಳ್ತೀವಿ. ಇಲ್ಲಿ ಭ್ರೂಣತಜ್ಞ ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟು ಈ ಒಂದು ART ಸೆಂಟ್ರಿಗೆ ಬ್ಯಾಕ್ ಬೋನ್ ಆಗಿ ಕೆಲಸ ಮಾಡ್ತಾರೆ. ಈ ಭ್ರೂಣ ತಜ್ಞ ಅಂತೂ ಏನು ಮಾಡ್ತೀವಿ ಅಂತಂತಂದರೆ ಮೊಟ್ಟೆ ಮತ್ತು ಸ್ಪರ್ಮ್ನು ಎರಡನ್ನೂ ಒಂದು ಇನ್ಕ್ಯುಬೇಟ್ರ್ ಅಂತ ಇರ್ತದೆ. ಅದು ಆ ಇನ್ಕ್ಯುಬೇಟ್ರು ಒಂದು ಫೀಮೇಲ್ನ ಯುಟ್ರಸ್ಗೆ ಕಂಪೇರ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಆ ಥರದ ಎನ್ವಿರಾನ್ಮೆಂಟ್ನ ಕ್ರಿಯೇಟ್ ಮಾಡಿ ಅಲ್ಲಿ ಒಂದು ಭ್ರೂಣ ಉತ್ಪತ್ತಿ ಮಾಡಿ ಭ್ರೂಣ ತಜ್ಞ ಅದನ್ನು 5 ದಿವಸದವರೆಗೂ ಕಾಪಾಡ್ಕೊಂಡು ಬರ್ತಾನೆ. ಇದನ್ನು ಮಾಡಬೇಕಾದ್ರೆ ತುಂಬ ಕ್ವಾಲಿಟಿ ಕಂಟ್ರೋಲ್ ಅಂತ ಇರ್ತದೆ. ಎಕ್ವಿಪ್ಮೆಂಟು ಏನು ಯೂಸ್ ಮಾಡ್ತೀವಿ, ಅಲ್ಲಿ ಏರ್ ಕ್ವಾಲಿಟಿ ಹೇಗಿರ್ತದೆ, ಪ್ರತಿ ದಿವಸ ನಾವು ಅದು ಹೇಗೆ ಮಾನಿಟರ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ, ಅದನ್ನು ಡಿಸ್ಟರ್ಬ್ ಮಾಡ್ಬೋದು. ಆದ್ದರಿಂದ ನಮಗೆ ಯಾವ ಥರದ ಭ್ರೂಣ ಬರುತ್ತೆ ಅಂತ ಗೊತ್ತಾಗುತ್ತೆ. ಖಂಡಿತವಾಗಿ ಒಳ್ಳೆ ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟು, ಒಳ್ಳೆ ಕ್ವಾಲಿಟಿ, ಒಳ್ಳೆ ಟೀಮ್ ಇದ್ದಾಗೆ ಒಳ್ಳೆ ಭ್ರೂಣ ಉತ್ಪತ್ತಿ ಆಗುತ್ತೆ. ಆ ಭ್ರೂಣನ ನಾವು ಇನ್ಫರ್ಟಿಲಿಟಿ ಫೀಮೇಲ್ಗೆ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡಿದಾಗ ಪ್ರಿಪೇರ್ ಮಾಡಿ ಅವ್ರದ್ದು ಎಂಡೋಮೆಟ್ರಿಯಮು ಖಂಡಿತವಾಗಿ ನಮಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಬರೋ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ.
ಓಕೆ ಡಾಕ್ಟರ್ ಭಾರತಿ, ಈಗ ಈ ಎಗ್ ಇವ್ರಿಗೆ ಸೂಟ್ ಆಗುತ್ತೆ, ಈ ಸ್ಪರ್ಮ್ ಇವ್ರಿಗೆ ಸೂಟ್ ಆಗುತ್ತೆ ಅಂತ ಹೇಗೆ ನೀವು ಸ್ಕ್ರೀನ್ ಮಾಡ್ತೀರಾ ಕ್ಯಾಂಡಿಡೇಟ್ಸ್ ಬಂದಾಗ?
See, we first before anything, okay, when the patient walks in, ask for the donor, they will be having priorities. They have to express their choices. So we keep in consideration those choices. Okay? So when we are selecting a donor, we keep certain criteria which gives a success for them. That is, the first and foremost is the age. As age advances, the fertility decreases. So the ICMR guidelines has given that when we select a woman, she should be around about 25 to 35 years of age, because they have a healthy egg and good genetic baby will be formed. Okay? To make it sure that this is so, what we do is, we personally, have a dialogue with the patient. So when we have a dialogue, we extract their history from them. Okay? The first consideration as soon as anyone walks in is the age. Okay? The next we see their BMI. That is the weight and the height, because even the obesity reduces the fertility, because it acts like an inflammation tissue. So keeping the age and this, and we take the physical characteristics of the woman. What are the physical characteristics? That is a woman. So the recipients who are taking the eggs are really, they will be in despair to know if the baby is born, will it be resembling me? Will it have the ears like me, or will it have the eyes like me? And will it be intellectual? There won't be any problem. So all this we keep in the mind before we selecting a donor egg or the donor sperm. So when we extract the history of the family, we exclude the family history. And if the donors have got particularly genetic diseases, because if they are carriers, we offer them genetic testing too. Apart from this, we take the blood group which is into consideration. The height, the weight, the color, the age, the blood group are the prominent. And usually we counsel the patient when we take the donor or the sperm. See, no two brothers are alike and no two sisters are alike. Isn't it? Little bit mismatch should be there, but
twins are only not
resembling you. Yes. ನಿಮ್ಮ ಥರ ಹೋಲುತ್ತೆ ಅದು, ಆದರೆ ಎಕ್ಸಾಕ್ಟ್ ಆಗಿ ಹೋಲೋದಿಲ್ಲ. ಬಟ್ ಬ್ಲಡ್ ಗ್ರೂಪ್ನ ಅವ್ರದ್ದು ಸೆಲೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಅಪಾರ್ಟ್ ಫ್ರಮ್ ದಿಸ್, ದ ಡೋನರ್ಸ್ಗೆ ನಾವು ವಿಗರಸ್ ಆಗಿ ಎಲ್ಲ ಟೆಸ್ಟ್ಗಳು ಮಾಡ್ತೀವಿ. ಲೈಕ್ ದೇರ್ ಈಸ್ ಫಾರ್ ಅಸ್ ದೇರ್ ಈಸ್ ಎ ಪ್ರೀ ಟೆಸ್ಟಿಂಗ್ ಸ್ಕೀಮ್, ದಟ್ ಈಸ್ ದ ಮೆಡಿಕಲ್ ಸ್ಕ್ರೀನಿಂಗ್ ವಿ ಕಾಲ್. ಅವ್ರಿಗೆ ಏನು ಕ್ಲಿನಿಕಲ್ ಆಗಿ ಏನು ಕಾಯಿಲೆ ಇಲ್ವಾ ಅಂತ ನಾವು ನೋಡಿ, ರೆಸ್ಪಿರೇಟರಿ ಸಿಸ್ಟಮ್, ಕಾರ್ಡಿಯಾಕ್ ಸಿಸ್ಟಮ್ ಇವೆಲ್ಲ ನೋಡ್ಕೊಳ್ತೀವಿ. ಏನು ತೊಂದರೆ ಇಲ್ಲ ಅಂತಾದಾದ್ಮೇಲೆ ವಿ ಪ್ರೊಜೆಕ್ಟ್ ದೆಮ್ ಫಾರ್ ಆಲ್ ದ ಬಯೋಕೆಮಿಕಲ್ ಟೆಸ್ಟ್. ಅವ್ರ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಕ್ಯಾರೆಕ್ಟರ್ ಹೆಂಗಿದೆ, ಎಲ್ಲ ಚೆನ್ನಾಗಿದೆಯಾ, ಅದೆಲ್ಲ ತಿಳ್ಕೊಂಡು ದೆನ್ ಓನ್ಲಿ ವಿ ರಿಕ್ರೂಟ್ ದೆಮ್ ಟು ದಿ ಡೋನರ್ ಸೈಕಲ್ ಪ್ರೋಗ್ರಾಮ್. ಇವಾಗ ಸ್ಪರ್ಮ್ಸ್ಗೆ ಹೋದರೆ ಸ್ಪರ್ಮ್ಸ್ಗೂ ನಾವು ಅದೇ ಥರ ನಾವು ನೋಡೋದು. ಓಕೆ, ದಿ ಹೈಟು, ದಿ ವೆಯ್ಟು, ದಿ ಕಲರು, ದಿ ಕಾರ್ನಿಯಾ, ದಿ ಬ್ಲಡ್ ಗ್ರೂಪ್, ಇದನ್ನೆಲ್ಲ ಸೆಲೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಆಮೇಲೆ ದಿಸ್ ಸ್ಪರ್ಮ್ಸ್ ಯೂಶಲಿ ವಿ ಟೇಕ್ ಇಟ್ ಫ್ರಮ್ ದಿ sperm bank, and for the oocytes there are two. For the eggs we can go for the oocyte bank, or we can go for the fresh collection. Fresh collection gives more success than that of the oocyte freezing. Yake andre namge particular we will be seeing them virtually than that. Okay, so all the patients ಇದರಲ್ಲಿ ನಮಗೆ ಸ್ವಲ್ಪ ತೊಂದರೆ ಆಗುತ್ತೆ. ಸ್ವಲ್ಪ ಜನ ಪೇಷಂಟ್ ದಾನಿಗಳು ನಮಗೆ ಏನಪ್ಪ ಈ ರಿಲಿಜನ್ ಅವ್ರು ಬೇಕು, ವೆಜಿಟೇರಿಯನ್ ಫುಡ್ ಅವ್ರು ಬೇಕು, ಈ ಥರ ಇರಬೇಕು, ಎಜುಕೇಷನ್ ಸ್ಟೇಟಸ್ ಈ ಥರ ಇರಬೇಕು, ಆ ಥರ ಎಲ್ಲ ಇರುವಾಗ ಅವನ್ನೆಲ್ಲ ಗಮನದಲ್ಲಿ ಇಟ್ಕೊಂಡು ಫಸ್ಟ್ ನಾವು ಅವ್ರ ಕಾನ್ಫಿಡೆನ್ಸ್ ತಗೊಳ್ತೀವಿ. ಓಕೆ, ದೆನ್ ವಿ ವಿಲ್ ಹ್ಯಾವ್ ಎ ಡೈಲಾಗ್ ಅವ್ರ ಹತ್ರ ಎಲ್ಲ ಪ್ರಫಾರ್ಮ ಚೆನ್ನಾಗಾದಾಗ ದೆನ್ ವಿ ವಿಲ್ ಪೋಸ್ಟ್ ದೆಮ್. ಆದರೆ ಏನಾದರೂ ಸ್ವಲ್ಪ ತೊಂದರೆ ಇತ್ತು ಅಂದ್ರೂ ವಿ ವಿಲ್ ಬಿ ಕ್ಯಾನ್ಸಲಿಂಗ್ ದೆಮ್. ಓಕೆ, ಆ್ಯಂಡ್ ದಟ್ ಟ್ರಸ್ಟ್ ವಿ ಶುಡ್ ಹ್ಯಾವ್ ವಿತ್ ಅವರ್ ಕ್ಲೈಯಂಟ್ಸ್. ಸೊ ಇದರಲ್ಲಿ ಮೇನ್ doctor who is involved is the team is led by the doctor. It is a multidisciplinary approach. Antandre embryologists, supportive group, avara they stand behind us. So if anything happens, yes, the doctor is in forefront who will answer their questions. So we have to take personal care, first to have a trust and then to build up the further conversation. So expertise management is very much important.
ಡೋನರ್ ಸಿನಿಮಾ ನೋಡಿದ್ರೆ ಅರ್ಥ ಆಗ್ಬಿಡುತ್ತೆ ಅನ್ಸುತ್ತೆ.
ನಾನು ಒಂದು ಎರಡು ಈಗ ICMR ಗೈಡ್ಲೈನ್ ಅನ್ನೋದು ಇಟ್ ಈಸ್ ನಾಟ್ ಇನ್ ಅ ಪಿಕ್ಚರ್ ಮೇಡಮ್. ನೌ ಇಟ್ ಈಸ್ ಎ ರೂಲ್. ಅಸಿಸ್ಟೆಡ್ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಟೆಕ್ನಾಲಜಿ ಆ್ಯಂಡ್ ಸರೋಗಸಿ ಇಟ್ ಈಸ್ ಇನ್ ಎ ರೂಲ್. ಇಟ್ ಹ್ಯಾಸ್ ಬೀನ್ ಪಾಸ್ಡ್. ICMR ವಾಸ್ ಇನ್ ಎ ಗೈಡ್ಲೈನ್. ನೌ ವಿ ಆರ್ ಬೌಂಡ್ ಟು ಫಾಲೋ ದ ರೂಲ್. ಇಫ್ ಯು ಡೋಂಟ್ ನಾವು ಈ ರೂಲನ್ನ ಫಾಲೋ ಮಾಡಲಿಲ್ಲ ಅಂತಂದರೆ ಅದರಲ್ಲೇ ನಮಗೆ ಏನು ಒಂದು ಸೆಂಟ್ರಲ್ಲಿ ಯಾರು ಇನ್ವಾಲ್ವ್ ಆಗಿರ್ತಾರೆ, ಯಾರು ಮಾಡ್ತಾರೆ, ಅವ್ರಿಗೆ ಇಷ್ಟು ಪೆನಾಲ್ಟಿ ಅಂತಂತ ಇರುತ್ತದೆ. ಮತ್ತು ಗೈಡ್ಲೈನ್ ಇಸ್ ಟು ಫಾಲೋ ಇಟ್. ರೂಲ್ ಇಟ್ ಹ್ಯಾಸ್ ಟು ಬಿ ಫಾಲೋಡ್. ರೂಲ್ನ ನಾವು ಫಾಲೋ ಮಾಡಲಿಲ್ಲ ಅಂದರೆ ವಿ ವಿಲ್ ಬಿ ಪೀನಲೈಸ್ಡ್. ಬಟ್ ಇದು ಡೋನರ್ ಎಗ್ಗು ಡೋನರ್ ಸ್ಪರ್ಮ್ಗೆ ಬಂದಾಗ ಮೊದಲು ಇದು ತುಂಬ ಸರಳವಾಗಿ ಆಗ್ತಾಯಿತ್ತು. ಯಾಕೆಂದರೆ ಕ್ಲಿನಿಷಿಯನ್ನೇ ಆಗಲಿ ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟೇ ಆಗಲಿ ಇದರಲ್ಲಿ ಜಾಸ್ತಿ ಎಡೆಕು ಇರಲಿಲ್ಲ. ಬಟ್ ಈಗ ರೂಲ್ಸ್ ಬಂದಾದ ಮೇಲೆ ನೀವು ಒಂದು ಡೋನರ್ನ ಸೆಲೆಕ್ಟ್ ಮಾಡಬೇಕಾದ್ರೆ ಅವರು ಕನ್ಸೆಂಟ್ ಕೊಡಬೇಕಾಗ್ತದೆ. ಇದನ್ನು ನಾವು ಕಮರ್ಷಿಯಲೈಸ್ ಮಾಡೋಂಗಿಲ್ಲ. ಈಗ ಒಂದು ಡೋನರ್, ಫೀಮೇಲ್ ಡೋನರ್, ಅವರು ಫೈರ್ ಆಗಿದ್ದಾರೆ, ಅವರು ಚೆನ್ನಾಗಿದ್ದಾರೆ, ನನಗೆ ಇದೇ ಡೋನರ್ ಬೇಕು, ನಾನು ಎಷ್ಟು ಬೇಕಾದ್ರೂ ದುಡ್ಡು ಕೊಡ್ತೀನಿ, ಈ ಥರದ್ದು ಇಲ್ಲ. ಯಾಕೆಂದರೆ ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಅನ್ನೋದೇ ಇದಕ್ಕೇ ಹೇಳೋದು. ಯಾಕೆಂತಂದರೆ ನೀವು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ ಯೂಸ್ ಮಾಡಬೇಕಾದ್ರೆ ಅದು ವಾಲಂಟಿಯರ್ಸ್. ಬಟ್ ಅನ್ಫಾರ್ಚುನೇಟ್ಲಿ ನಮ್ಮ ಇಂಡಿಯನ್ ಸಿನಿಯಾರದಲ್ಲಿ ಇದು ಆಗೋದಿಲ್ಲ. ಯಾರೇ ಮುಂದೆ ಬಂದರೂ ಅವ್ರಿಗೆ ಮಾನಿಟ್ರಿ ವೈಸು ಸ್ವಲ್ಪ ಕಾಂಪನ್ಸೇಟ್ ಮಾಡಬೇಕಾಗ್ತಾಯಿದೆ. ನಾನು ಕೂಡ ಒಂದು ART ಬ್ಯಾಂಕ್ ಅನ್ನೋದನ್ನು ರನ್ ಮಾಡ್ತಾಯಿದ್ದೀನಿ. ಇಲ್ಲಿ ವಾಲಂಟಿಯರ್ಸ್ ಆಗಿ ಸಿಮೆಂಟ್ ಡೋನರ್ಸ್ ಬರ್ತಾರೆ, ಆಮೇಲೆ ಫಿಮೇಲ್ ಡೋನರ್ ಊಸೈಟ್ ಮಾಡೋರು ಬರ್ತಾರೆ. ಅವ್ರಿಗೆ ನಾವು ಮೊದಲಾಗಿ ಸ್ಕ್ರೀನಿಂಗ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಸೆಕ್ಷುವಲಿ ಟ್ರಾನ್ಸ್ಫರ್ ಡಿಸೀಸ್ ಇದೆಲ್ಲ ಇದೆಯಾ ಅಂತ ಫ್ಯಾಮಿಲಿ ಪಿಡಿಗ್ರಿ ಮಾಡಬೇಕಾಗ್ತದೆ. ಯಾವುದು ಬ್ಲಡ್ ಗ್ರೂಪು, ಕಂಪ್ಲೆಕ್ಷನ್ ಏನು, ಏರ್ ಕಲರು, ಐ ಕಲರು, ದೀಸ್ ಆರ್ ದ ಮೇಜರ್ ಪ್ರೊಫೈಲನ್ನು ನಾವು ಸೆಲೆಕ್ಟ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಇದನ್ನು ಮಾತ್ರ ಮ್ಯಾಚ್ ಮಾಡೋಕ್ಕೆ ಆಗೋದು. ಯಾಕೆಂತಂದರೆ ನಮ್ಮಲ್ಲಿ ಈ ಥರದ ವಾಲಂಟಿಯರ್ಸು ತುಂಬ ಕಡಿಮೆ. ಮಾನಿಟ್ರಿ ವೈಸು ಡಿಮ್ಯಾಂಡ್ ಮಾಡಿದಾಗ ಮಾತ್ರ ಈ ಥರ ಡೋನರ್ಸ್ ಬರ್ತಾರೆ ಹೊರತು ವಾಲಂಟ್ರಿಗೆ ಬಂದು ನಾನು ಐ ವಿಲ್ ಬಿ ಏಬಲ್ ಟು ಡೊನೇಟ್. ನಿಮಗೆ ಗೊತ್ತಿರಬೇಕು, ಒಂದು ಎರಡು ಸೆಲೆಬ್ರಿಟೀಸ್, ಬಾಲಿವುಡ್ ಸೆಲೆಬ್ರಿಟೀಸ್, ದೇ ಹ್ಯಾವ್ ಅಂಡರ್ಗಾನ್ ಸರೋಗಸಿಸ್ ಬಿಕಾಸ್ ದೇ ಡಸಂಟ್ ವಾಂಟ್ ಟು ಬೇರ್ ದ ಚೈಲ್ಡ್. ದಿಸ್ ಈಸ್ ಬಿಫೋರ್ ದ ಆ್ಯಕ್ಟ್ ಹ್ಯಾಸ್ ಕಮ್ ಇನ್ ಟು ದ ಪಿಕ್ಚರ್. ಇದನ್ನು ನಾವು ಕಮರ್ಷಿಯಲೈಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ, ಫೀಮೇಲ್ನ ಅಬ್ಯೂಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ ಅಂತ ಆದಾಗ ಮಾತ್ರ ಇದು ಬಂತು. ಈಗ ಒಂದು ಸರೋಗಸಿ ಮಾಡಬೇಕು ಅಂದರೆ ಸುಮಾರು ಸ್ಟೆಪ್ಸ್ಗಳಿದೆ. ಅವ್ರಿಗೆ
ರೂಲ್ಸ್ ಏನಿದೆ ಸ್ವಲ್ಪ ಕ್ರಿಸ್ಪ್ ಆಗಿ,
ಅವ್ರಿಗೆ ಮೊದಲು ಸರ್ಟಿಫಿಕೇಷನ್ ಆಗಬೇಕಾಗ್ತದೆ. ಈಗ ಯಾವುದಾದ್ರೂ ಒಂದು ಫೀಮೇಲನ್ನ ನಾನು ಐಡೆಂಟಿಫೈ ಮಾಡಿದೆ ಅಂತಂದರೆ ರಿಸಿಪಿಯೆಂಟ್ ಕಪಲ್ಗೆ, ಗಾರ್ಡಿಯನ್ ಕಪಲ್ಗೆ ಅವರು ಮೊದಲು ನಾನು ಐ ವಿಲ್ ಟೆಲ್ ಯು ಮೈ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್. ಐ ಹ್ಯಾವ್ ಟು ಸೆಂಡ್ ಟು KC ಜನರಲ್ ಹಾಸ್ಪಿಟಲ್. ಅಲ್ಲಿ ಗೌರ್ಮೆಂಟ್ ಗೈನೆಕ್ಸ್ ನೋಡ್ತಾರೆ, ಸೈಕಾಲಜಿ ಬೇರೆ ಬೇರೆ ಡಿಪಾರ್ಟ್ಮೆಂಟಲ್ಲಿ ಅವರು ಹೋಗಬೇಕಾಗುತ್ತದೆ. ಅವರು ಸೂಟಬಲ್ಲ, ಕಮರ್ಷಿಯಲ್ ಆಗಿ ಮಾಡ್ತಾ ಇದ್ದಾರಾ, ಯಾವುದು ಮಾನಿಟ್ರಿ ವೈಸ್ ಮಾಡ್ತಾ ಇದ್ದಾರಾ, ಇದನ್ನೆಲ್ಲ ಮಾಡ್ತಾರೆ. ತದನಂತರ ಅವರು ಕೋರ್ಟ್ಗೆ ಹೋಗಬೇಕಾಗ್ತದೆ. ರಿಸಿಪಿಯೆಂಟ್ ಕಪಲು ಕೋರ್ಟ್ಗೆ ಹೋಗಬೇಕಾಗ್ತದೆ, ಅಫಿಡೇವಿಟ್ ಮಾಡಬೇಕಾಗ್ತದೆ. ಕೋರ್ಟ್ನಲ್ಲಿ ಮ್ಯಾಜಿಸ್ಟ್ರೇಟರು ಓಕೆ ಈ ಕಪಲ್ಗೆ ನೀವು ಸರಗೇಟಿ ಮಾಡ್ಬೋದು. ಅದಾದ ನಂತರದ ಆರೋಗ್ಯ ಭವನಕ್ಕೆ ಹೋಗಬೇಕಾಗ್ತದೆ. ಅಲ್ಲಿ ಇದಕ್ಕೆ ಸಂಬಂಧಪಟ್ಟಂತೆ ಒಬ್ಬರು ಚೇರ್ಮನ್ ಅಂತ ಇರ್ತಾರೆ, ಮೇಯ್ನಾಗಿ ಕಮಿಷನರು. ಅವ್ರ ಕಡೆಯಿಂದ ಸರ್ಟಿಫಿಕೇಟ್ ಬಂದರೆ ಮಾತ್ರ ಆಗ ಆ ಸರ್ಟಿಫಿಕೇಟ್ಗೆ 2 ವರ್ಷಗಳ ಕಾಲ ಇರ್ತದೆ. ಆ 2 ವರ್ಷ ಕಾಲದಲ್ಲಿ ಅವರು ಈ ಸರೋಗಸಿಗೆ ಹೋಗ್ಬೋದು. ಏನಕ್ಕೆಂದರೆ ನಾನು ಅಲ್ಲಿ ಒಬ್ಬ ಎಕ್ಸ್ಪರ್ಟ್ ಕಮಿಟಿ ಆಗಿ ಮೆಂಬರ್ ಆಗಿದ್ದೀನಿ. ದಿನೇಶ್ ಗುಂಡೂರಾವ್ ಇದ್ದಾರೆ, ಹೆಲ್ತ್ ಮಿನಿಸ್ಟ್ರು. ಅದ ನಂತರ PCPNDT ಆ್ಯಕ್ಟರ್ ಡಾಕ್ಟರ್ ವಿವೇಕ್ ದೊರೆ ಅವರು ಬಂದಿದ್ದರು. ಆಮೇಲೆ ಇದು ಒಂದು ನ್ಯಾಷನಲ್ ಬೋರ್ಡ್ ಆದ ನಂತರ ಸ್ಟೇಟ್ ಬೋರ್ಡು ಈಗ ನಾವು ಒಂದು ಸಾಫ್ಟ್ವೇರ್ ಅಂತ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. ಯಾವುದೇ IVF ಸೆಂಟ್ರಲ್ಲಿ ಏನೇ ಪ್ರೋಗ್ರಾಮ್ ಮಾಡಿದ್ರು 1 ವೀಕ್ ಆದಮೇಲೆ ಅವರು ಎಂಟ್ರಿ ಮಾಡಬೇಕಾಗ್ತದೆ, ಸ್ಕ್ರೂಟಿನಿಗಳಾಗ್ತದೆ, ಮ್ಯಾಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಆಗಬಾರ್ದು ಅಂತ. ಸೊ ಹೀಗಾಗಿ ನವೆಡೇಸ್ ಇಟ್ ಈಸ್ ಬಿಕಮಿಂಗ್ ವೆರಿ tedious ಫಾರ್ ಕ್ಯಾರಿಂಗ್ ಔಟ್ ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್.
ಆದರೆ ಈಗಲೂ ಅಷ್ಟೇ, ನನ್ನ ಹತ್ರನೂ ಅಷ್ಟೇ ಎಷ್ಟೋ ಜನ ಈಗ ಬರ್ತಾರೆ. ದೇರ್ ಆರ್ 2 types of approaches, ಆಲ್ಟ್ರುಯಿಸ್ಟಿಕ್ ಅಪ್ರೋಚ್ ಆ್ಯಂಡ್ ಕಮರ್ಷಿಯಲ್ ಅಪ್ರೋಚ್. ಹೇಳ್ತಾರೆ ನಮ್ಮ ಅಕ್ಕ, ನಮ್ಮ ತಂಗಿ, ನಮ್ಮ ಕಸಿನ್ ಸಿಸ್ಟರು ನಮಗೆ ದುಡ್ಡು ಆಗೋದಿಲ್ಲ, ಸೊ ಅವ್ರನ್ನ ನಾವು ಮಾಡ್ಬೋದಾ ಅಂತ. ಎಸ್, ನಾವು ಈಗ ಸ್ವಲ್ಪ ರೂಲ್ಸ್ ಸ್ವಲ್ಪ ವೇವ್ ಆಗಿರೋದ್ರಿಂದ ವಿ ಕ್ಯಾನ್ ಟೇಕ್ ದಾನಿಗಳು ಫ್ರಮ್ ಅವರ್ ರಿಲೇಟಿವ್ಸ್, ಬಟ್ ನಾಟ್ ಫ್ರಮ್ ಪೇರೆಂಟ್ಸ್ ಆರ್ ಎನಿಥಿಂಗ್. ಇಟ್ ಶುಡ್ ಬಿ ಕಸಿನ್ಸ್ ಸಿಸ್ಟರ್ಸ್ ಆರ್ ಫ್ರಮ್ ದಿ ರಿಲೇಟಿವ್ಸ್ whom they know. ಆವಾಗ ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಫೈನಾನ್ಷಿಯಲ್ ಮ್ಯಾನೇಜ್ಮೆಂಟ್ಗೆ ತುಂಬ ಈಸಿ ಆಗುತ್ತೆ. ಓಕೆ, ಸೊ ಅದೊಂದು ಸ್ವಲ್ಪ ರೂಲ್ ಸ್ವಲ್ಪ ವ್ಯತ್ಯಾಸ ಆಗ್ತಾ ಇದೆ. ಸೊರೊಗಸಿನೂ ಅಷ್ಟೇ, ಅವ್ರ ಕಡೆಯಿಂದ ಕರ್ಕೊಂಬಂದು ಅವ್ರು ಮಾಡ್ಬೋದು ಈಗ. ಸೊ ಆದರೆ ಲಿಗ್ಯಾಲಿಟೀಸ್ ಎಲ್ಲ ಇದೆ, ವಿ ಹ್ಯಾವ್ ಟು ಗೋ ಥ್ರೂ ದ ಲಿಗ್ಯಾಲಿಟೀಸ್. ಇದಕ್ಕೆ ಕಮಿಷನಿಂಗ್ ಏಜೆಂಟ್ಸು ಇದ್ದಾರೆ, ಬಟ್ ಕಮಿಷನಿಂಗ್ ಏಜೆಂಟ್ ವಿಲ್ ಬಿ ಮೋರ್ ಎಕ್ಸ್ಪೆನ್ಸಿವ್. ಆವಾಗ ಅವರೇ ಹೋಗಿ ಅಫಿಡವಿಟ್ ಮಾಡಿಸಿ ಡಾಕ್ಟರ್ ಶ್ರೀನಿವಾಸ್ ಹೇಳ್ದಂಗೆ ಮಾಡ್ಬೋದು. ಓಕೆ, ಸೊ ಇಟ್ ವಿಲ್ ಬಿ ಯೂಸ್ಫುಲ್ ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಸೊ ದಟ್ ಯಾರಿಗೆ ಆಗಲ್ಲ, ಯಾವ ಯಂಗ್ಸರ್ಗೆ ಫಿಸಿಕಲಿ ಫಿಸಿಕಲಿ ಹ್ಯಾಂಡಿಕ್ಯಾಪ್ ಇರ್ತಾರೆ, ಅಥವಾ ಕಾರ್ಡಿಯಾಕ್ ಡಿಸೀಸಸ್, ಮೆಡಿಕಲ್ ಡಿಸೀಸಸ್, ಅಥವಾ ಅವ್ರಿಗೆ ಮಗು ಆಗಲ್ಲ ಅಂತ ಇರುತ್ತೋ ಅವರು ಸೊರೊಗೇಟ್ ಅವ್ರನ್ನ ತಗೊಳ್ಬೋದು.
ಈಗ ಒಂದೇ ಒಂದು ಟರ್ಮ್ನ ಆ್ಯಡ್ ಮಾಡಿದ್ದಾರೆ ಮೇಡಮ್ ಹೇಳ್ದಂಗೆ, ಅಲ್ಟ್ರುಸ್ಟಿಕ್ ಅಂತಂದರೆ ಇಟ್ ಈಸ್ ವೆರಿ ಕಾಮನ್. ಯಾರು ಮುಂದೆ ಬರ್ತಾರೆ ವಾಲಂಟರಿಯಾಗಿ ಹೆಲ್ಪ್ ಮಾಡೋದಂತ. ಇಟ್ ಮೇ ನಾಟ್ ಬಿ ಓನ್ ಫ್ಯಾಮಿಲಿ, ಇಟ್ ಕ್ಯಾನ್ ಬಿ ಅದರ್ ಫ್ಯಾಮಿಲಿ ಆಲ್ಸೋ. ಅದಕ್ಕೋಸ್ಕರ ನಾವು ಯಾವಾಗಾದ್ರೂ ಕಾನೂನು ಮಾಡಬೇಕಾದ್ರೆ ನಮ್ಮ ಈ ಜಿಯೋಗ್ರಫಿಕಲ್ ಇದರಲ್ಲಿ ಯಾವ ಥರ ಪಾಪ್ಯುಲೇಷನ್ ಇದೆ, ಅವ್ರದ್ದೆಲ್ಲ ಲೈಫ್ ಸ್ಟೈಲ್ ಹೇಗಿದೆ, ಹೇಗೆ ಯುಟಿಲೈಸ್ ಆಗುತ್ತೆ, ಆ ಥರ ಮಾಡಬೇಕಾಗ್ತದೆ. ನಮ್ಮ ಇಂಡಿಯನ್ ಸಿನಾರಿಯೋ ಇಫ್ ಯು ಟೇಕ್ ಇನ್ ಎ ನಾರ್ತ್, ಸೌತ್, ವೆಸ್ಟ್, ಲೈಫ್ ಸ್ಟೈಲ್, ಜಿಯೋಗ್ರಫಿಕಲ್ ಡಿಫ್ರೆನ್ಸ್, ಎವ್ರಿಥಿಂಗ್ ಈಸ್ ಡಿಫ್ರೆನ್ಸ್. ನಾವು ಅದನ್ನು ಮಾಡಬೇಕು. ಈಗ ಅದಕ್ಕೋಸ್ಕರ ಅಲ್ಟ್ರುಸ್ಟಿಕ್ ಅಂತ ಆದಾಗ ನಾವು ನಮ್ಮ ಫ್ಯಾಮಿಲಿಲೇ ಯಾರು ಬಂದರೆ ಇಟ್ಸ್ ಓಕೆ, ಇಲ್ಲ ಅಂತಂದರೆ ದೋಸ್ ಹು ಕಮ್ ಇನ್ ಫೇವರ್ ಆಫ್ ಹೆಲ್ಪಿಂಗ್ ಔಟ್ ಇನ್ಫರ್ಟೈಲ್ ಕಪಲ್, ದಟ್ ಈಸ್ ಅಕ್ಸೆಪ್ಟೆಡ್.
Actually, many of them are not aware of these rules.
ಇದಕ್ಕೊಂದು ತುಂಬ ಇಂಪಾರ್ಟೆಂಟ್ ಇದೆ. ಯಾಕೆ ಅಂತಂದರೆ ಡೋನರ್ ಸ್ಪರ್ಮ್ಸು, ಡೋನರ್ ಎಗ್ಸ್ಗೆ ಯಾಕೆ ಅಂದರೆ ಲೆಜಿಮಿಟ್ ಏನಪ್ಪ ಆ ಮಕ್ಕಳು ವಾರಸ್ದಾರಾಗ್ತಾರೆ ಆರ್ತಿಗೆ. ನಾನೊಂದು ಎಕ್ಸಾಂಪಲ್ ಹೇಳ್ತೀನಿ. ನಾನೊಂದಲ್ಲೇ ಹಾಸ್ಪಿಟ್ಲಲ್ಲಿ ನನ್ನ ಕೆಲಸ, ಆ ಹಾಸ್ಪಿಟಲ್ ನೇಮೆಲ್ಲ ಹೇಳೋದಿಲ್ಲ. ಓಕೆ, ಈ ಮೆಟ್ ವಿತ್ ಆಕ್ಸಿಡೆಂಟ್ ಆದಾಗ ಓಕೆ ಈ ವಾಸ್ ಬ್ರೈನ್ ಡೆತ್ ಆಗಿತ್ತು. ಸೊ ಹಾಸ್ಪಿಟ್ಲಿಂದ ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ಗೆ ಹೋದರು. ಆರ್ಗನ್ ಟ್ರಾನ್ಸ್ಪ್ಲಾಂಟ್ಗೆ ಹೋದಾಗ ಲಿವರ್ ತಗೊಂಡ್ರು, ಕಿಡ್ನೀಸ್ ತಗೊಂಡ್ರು. ದೆನ್ ದೇ ಗೇವ್ ಮಿ ಇಮಿಡಿಯೇಟ್ ಕಾಲ್, ಡಾಕ್ಟರ್ ದ ವೈಫ್ ಈಸ್ ಆಸ್ಕಿಂಗ್ ಫಾರ್ ಹಿಸ್ ಸ್ಪರ್ಮ್ಸ್, ವಾಟ್ ವಿಲ್ ಯು ಡೂ? So I told, please wait, I will come down. Okay, because already they were in the OT. I told there is no rule to take the sperms from the dead person, though the wife wants or though the family wants. ಯಾಕೆ ಅಂತಂದರೆ ಅವ್ರು ಆ ಮಗು ಮಾಡಿಕೊಂಡು ವಾರಸ್ದಾರರಾಗಿ ಅವ್ರದ್ದು ಮುಂದಿನ ಇದಾಗುತ್ತೆ, ಅವ್ರದ್ದು ಪ್ರಾಪರ್ಟಿ ಎಲ್ಲ ತಗೊಳ್ಬೋದು ಅಂತ. ಸೊ ಎ ವಿಡೋ ಈಸ್ ನಾಟ್ ಅಲೌಡ್ ಟು ಟೇಕ್ ಎ ಸ್ಪರ್ಮ್ಸ್ ಫ್ರಮ್ ದಿ dead person.
No madam, let me clarify. Very recently Supreme Court has reviewed it. Actually, not only the female, parents also can go use that sperm sample of the husband posthumously, because parents has gotten a right. And in your case actually, if she is married, her sperm sample can be, see, their vested interest is different. That lady has a right, she is legitimately married. Okay,
but
if the husband is
not
dead,
allowed
husband
to take
is
the
dead,
sperms from the dead person.
No, with the consent.
No,
if
not with the
if
consent.
the brain dead,
they have to get legal immediately.
No,
they
no,
cannot
no.
take within the terms. So I had a legal advisor and I took, and they told no. Because
actually, not just you, doctor, many of them are not aware of the rules and regulations.
Leave the father-in-law and the mother-in-law and go only for the property she can have the child. So they told no, it is not allowed.
Okay.
No madam, Brain dead, it is not declared. Wife can avail it because she is legitimately married. What is
See,
property, what is
this
going
is
to
the
happen,
one which
it's
is
okay.
still, the guidelines are not proper
single
now.
woman, even if she doesn't use her own married husband sample also, she has a right to use some other sample, second option. And as a male, I cannot use somebody's egg. In rule, it is not allowed. Single woman, it is allowed.
Yeah.
It is in the
If
rule.
the husband gives a consent, she can have. If she is married, if it is a single, okay? But if it is not, it comes as adultery. So these laws are still not well formed, so that it needs further depth to go into this one, to
No,
study
actually,
and to
Bollywood
formulate it.
celebrities have actually glorified surrogacy so much that people they're not aware of the rules of actually.
Pardon?
Which Bollywood celebrities and all have actually glorified surrogacy to an extent that people are not aware of the rules. They just think it's fancy to have
Yeah, it is fancy,
kids
true.
and things like
That's
that. Thanks for
exactly.
the rules, but continuing with our topic, maybe
Yeah.
we can, doctor, if you can just tell us what are the complications you face for a successful fertilization.
Okay, this is something else. As a ಎಂಬ್ರಿಯಾಲಜಿಸ್ಟ್ ಒಬ್ಬ ಭ್ರೂಣ ತಜ್ಞ ಒಂದು ಎಂಬ್ರಿಯಾಲಜಿ IVF ಲ್ಯಾಬ್ನಲ್ಲಿ ಮೊಟ್ಟೆ ಮತ್ತು ವೀರ್ಯಾಣು ಮತ್ತು ಮೊಟ್ಟೆನ ಹೇಗೆ ಪೋಷಿಸ್ಕೊಂಡು ಹೋಗಬೇಕಾಗ್ತದೆ ಅನ್ನೋದು, ದಿಸ್ ಈಸ್ ಸಮಥಿಂಗ್ ಎಲ್ಸ್ ಇಸ್ ವೆರಿ ಡಿಫ್ರೆಂಟ್ ಬಿಕಾಸ್ ನೋ ಇಟ್ ಈಸ್ ಕಮ್ಸ್ ಬೈ ದ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ ಎಕ್ಸ್ಪರ್ಟೈಸ್ ಲೈಕ್ ಎನಿ ಮೇಜರ್ ಸರ್ಜನ್ ಎನಿ ಮೇಜರ್ ಎಕ್ಸ್ಪೀರಿಯನ್ಸ್ಡ್ ಕ್ಲಿನಿಷಿಯನ್ಸ್ ಡಸ್ ಇಸ್ ಓಟಿ ವರ್ಕ್. ಅದೇ ಥರದಲ್ಲಿ ಒಂದು ವೀರ್ಯಾಣು ಒಂದು ಮೊಟ್ಟೆನ ಜೊತೆಗೆ ಸೇರಿಸಿ ಅದನ್ನು ಭ್ರೂಣ ಮಾಡಿ ಅದನ್ನು 2 ದಿವಸ 3 ದಿವಸ 4 ದಿವಸ ಒಂದು ಹಂತದವರೆಗೆ ತೆಗೆದುಕೊಂಡು ಹೋಗಿ ಅದನ್ನು ಗರ್ಭಕೋಶಕ್ಕೆ ಹಾಕ್ತೀವಿ. ಅದು ಮಾಡಬೇಕಾದರೆ ಒಂದು ಹಂತದಿಂದ ಒಂದು ಹಂತದವರೆಗೂ ಭ್ರೂಣ ಇದು ಹೇಗೆ ಡೆವಲಪ್ ಆಗ್ತದೆ, ಯಾಕೆಂದರೆ ಒಂದು ಹಂತದಿಂದ ಒಂದು ಡೆವಲಪ್ಮೆಂಟ್ ಇರ್ತದೆ. ಆ ಒಂದು ಡೆವಲಪ್ಮೆಂಟ್ ಇದ್ದಾಗ ಮಾತ್ರ ಈ ಭ್ರೂಣ ಅತಿ ಹೆಚ್ಚಾಗಿ ಚೆನ್ನಾಗಿದೆ, ಇದನ್ನು ನಾವು ಸೆಲೆಕ್ಟ್ ಮಾಡ್ಬೋದು. ಇದನ್ನು ಸೆಲೆಕ್ಟ್ ಮಾಡೋದ್ರಿಂದ ಇಂಪ್ಲಾಂಟೇಷನ್ ಆಗ್ಬೋದು, ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗ್ಬೋದು ಅಂತ ಇರ್ತದೆ. ಇದು ಮಧ್ಯದಲ್ಲಿ ಡಿಪೆಂಡಿಂಗ್ ಆನ್ ದ ಕೇಸ್ ಹಿಸ್ಟ್ರಿ ನಾವು ಇದು ಒಂದು ಬ್ಲಾಸೋಸಿಸ್ ಸ್ಟೇಜ್ಗೆ ತಗೊಂಡು ಹೋಗ್ಬೋದಾ, ಎಗ್ನ ಯಾವ ಥರ ಮಾನಿಟರ್ ಮಾಡಬೇಕಾಗುತ್ತೆ, ಅಥವಾ ಭ್ರೂಣನ ಯಾವ ಥರ ಮಾನಿಟರ್ ಮಾಡಬೇಕಾಗ್ತದೆ, ಒಳ್ಳೆ ಭ್ರೂಣನ ನಾವು ಹೇಗೆ ಸೆಲೆಕ್ಟ್ ಮಾಡಬೇಕಾಗ್ತದೆ, ಇದಕ್ಕೆ ಅಡ್ವಾನ್ಸ್ಡ್ ಟೆಕ್ನಾಲಜಿ ಎಲ್ಲ ಇರ್ತದೆ. ಈ ಒಂದು ಅಡ್ವಾನ್ಸ್ಡ್ ಟೆಕ್ನಾಲಜಿನ ಯೂಸ್ ಮಾಡಿ ನಾವು ಆ ಭ್ರೂಣವನ್ನು ಸೆಲೆಕ್ಟ್ ಮಾಡೋದ್ರಿಂದ ನಾವು ಒಂದು ಪ್ರೆಗ್ನೆನ್ಸಿ ರೇಟನ್ನ ಇನ್ಕ್ರೀಸ್ ಮಾಡ್ಬೋದು ಅಂತ ಹೇಳ್ಬೋದು.
ಡಾಕ್ಟರ್ ಭಾರತಿ, ಈಗ ಅನಾನಿಮಿಟಿ ತುಂಬ ಇಂಪಾರ್ಟೆಂಟ್ ಡೋನರ್ಸ್ ಅಲ್ಲಿ. ಸೊ ಹೌ ಡು ಯು ಮೇಂಟೈನ್ ಕಾನ್ಫಿಡೆನ್ಷಿಯಲಿಟಿ?
Anonymity, yes. First, we should have, see, this is a multidisciplinary approach again. ಡಾಕ್ಟ್ರು ಒಬ್ಬರಿಂದನೇ ಆಗಲ್ಲ. ಒಬ್ಬರು ಡೋನರ್ ಬಂದರು ಅಂತ ತಿಳ್ಕೊಳ್ಳಿ, ಅವರು ಡಾಕ್ಟರ್ ಅನಾನಿಮಿಟಿ ಹೇಳ್ದಿರ ಯಾರಿಗಾದ್ರೂ ಇರಬಹುದು. ಆದರೆ ಅವ್ರ ಸ್ಟಾಫ್ಸ್ ಅವ್ರನ್ನೆಲ್ಲ ಅದಕ್ಕೆ ರೆಗ್ಯುಲರ್ ಆಗಿ ವಿ ಶುಡ್ ಹ್ಯಾವ್ ಮೀಟಿಂಗ್ಸ್, ವಿ ಶುಡ್ ಹ್ಯಾವ್ ಆಡಿಟ್, ಓಕೆ, ಆ್ಯಂಡ್ ಕನ್ಸೆಂಟ್ ಫಾರ್ಮ್ಸ್ ಅಂತ ಇರುತ್ತೆ. ಸೊ ವಿ ವಿಲ್ ಬಿ ಫಿಲ್ಲಿಂಗ್ ಅಪ್ ಆಲ್ ದೋಸ್ ಕನ್ಸೆಂಟ್ ಫಾರ್ಮ್ಸ್ ಆ್ಯಂಡ್ ಟೇಕ್ ಆ್ಯಂಡ್ ಕೀಪ್ ದ ಪ್ರೈವಸಿ ಫಾರ್ ದಿ ಡೋನರ್ ಅವ್ರು ಬಂದಾಗ. ಸೊ ಆಮೇಲೆ ಇನ್ನೊಂದು ವಿ ಹ್ಯಾವ್ ಟು ಫೋಸ್ಟರ್ ದೆಮ್ ವಿತ್ ರೆಸ್ಪೆಕ್ಟ್. ಫಾರ್ ಸಮ್ ಟೈಮ್ಸ್ ವಿ ಹ್ಯಾವ್ ಸೀನ್ ದ ಪರ್ಸನಲ್ ವಿಲ್ ಫೀಲ್ ಅನಾಯ್ಡ್, okay, without any proper respect or privacy or anything, okay, but we have to be transparent too, okay. We need to tell them what is necessary, what information to be given and properly recorded. So it also needs a team, and privacy and confidential is kept so that there won't be rift in the family later, okay.
Okay, Dr. Srinivas, how
anonymity is a big problem now, madam, after this ART rule has come. ಇಫ್ ನಾನು ಒಂದು ಡೋನಾರ್ ಪ್ರೋಗ್ರಾಮ್ ಮಾಡ್ತಾ ಇದ್ದೀನಿ ಅಂತಂದರೆ ಅವರು ಒಂದು ಆಧಾರ್ ಕೊಡಬೇಕಾಗ್ತದೆ, ಆಧಾರ್ ಕಾರ್ಡ್ ಕೊಡಬೇಕಾಗ್ತದೆ. ಆಧಾರ್ ಕಾರ್ಡನ್ನು ನಾನು ಯಾವ ಸೆಂಟರ್ಗೆ ಡೋನಾರ್ ಸ್ಯಾಂಪಲ್ ಕಳಿಸ್ತೀನಿ ಅಥವಾ ಡೋನಾರ್ ವೆಬ್ಸೈಟ್ಗೆ ಕಳಿಸ್ತೀನಿ ಅಂದಾಗ ಆಧಾರ್ ಕಾರ್ಡು ನಾವು ಶೇರ್ ಮಾಡಿದಾಗ ಅನಾನಿಮಿಟಿ ಅನ್ನೋದು ಒಂದು ಕಾಂಪ್ರಮೈಸ್ ಆಗ್ತದೆ. ಮೊದಲು ICMR ಗೈಡ್ಲೈನ್ ಇದ್ದಾಗ ಅನಾನಿಮಿಟಿ ಅನ್ನೋದನ್ನು ನಾವು ಇಡ್ತಾ ಇದ್ದೋ. ಈಗ ಆಧಾರ್ ಕಾರ್ಡ್ ಕೊಡೋದ್ರಿಂದ ಬಿಕಾಸ್ ಇಟ್ ಈಸ್ ಅದು ಒಂದು ART ಸೆಂಟ್ರಲ್ಲಿ ಮಾತ್ರ ಇರೋದಿಲ್ಲ, ಅದನ್ನು ನಾನು ಬೇರೆ ಒಂದು ಸೆಂಟ್ರಿಗೆ ಶೇರ್ ಮಾಡಿರೋದ್ರಿಂದ ಅಲ್ಲಿ ಒಬ್ಬರ ಕೈನಲ್ಲಿ ಇರೋದಿಲ್ಲ ಇದು. ಒಂದು ರಿಸೆಪ್ಷನ್ಗೆ ಹೋಗ್ತದೆ, ಅದೊಂಥರ ಫೈಲ್ಗೆ ಹೋಗ್ತದೆ, ಬೇರೆ ಎಲ್ಲ ಹೋಗ್ತದೆ. ಹಾಗಾಗಿ ಈ ಒಂದು ಅನಾನಿಮಿಟಿ ಅನ್ನೋದು ಸ್ವಲ್ಪ ಬ್ರೇಕ್ ಆಗಿದೆ. ಇದರಿಂದ ಫ್ಯೂಚರಲ್ಲಿ ಈ ಒಂದು ಪ್ರೊಸೀಜರ್ ಮಾಡಿ ಮಗು ಆದಾಗ ಸೋಷಿಯಲ್ ಪ್ರಾಬ್ಲಮ್ ಮೇ ಅರೈಸ್. ದಿಸ್ ಇಸ್ ದ ಒನ್ ಕನ್ಸರ್ನ್ ಆ್ಯಕ್ಚುಲಿ. ದಿಸ್ ವಿ ಹ್ಯಾವ್ ಬೀನ್ ಎಕ್ಸ್ಪ್ಲೋರಿಂಗ್ ಇಟ್ ಆ್ಯಕ್ಚುಲಿ. ರಿವ್ಯೂ ಮಾಡಿದ್ರೆ ಅನಾನಿಮಿಟಿ ಇದ್ದಾಗ ವಿ ವಿಲ್ ಬಿ ಏಬಲ್ ಟು ಬ್ರೇಕ್ ದಿಸ್ ಕೈಂಡ್ ಆಫ್ ನೋ.
ಸೊ ಡಾಕ್ಟರ್, ಈಗ ಸರೋಗೇಟ್ ಆಗಬೇಕಂದ್ರೆ ಅವ್ರ ಮೆಡಿಕಲ್ ಕಂಡೀಷನ್ಸ್ ಹೇಗಿರಬೇಕು?
ಮೇಡಮ್ ಹೇಳ್ತಾರೆ.
ಓಕೆ, ಫಸ್ಟ್ ಸೊರಗೇಟ್ನ ಏನಾದರೂ ಚೂಸ್ ಮಾಡಬೇಕು ಅಂದಾಗ ಫಸ್ಟ್ ನಾವು ಅದೇ ಏಜೇ ಫಸ್ಟ್ ಇಂಪಾರ್ಟೆಂಟ್ ವೇರ್ ವಿ ಗೋ ಇನ್ ಟು. ಓಕೆ, ಎನಿಬಡಿ ಬಿಟ್ವೀನ್ ದ ಏಜ್ ಆಫ್ 25 to 35. ಯಾಕೆ ಅಂತಂದರೆ ಅವ್ರಿಗೆ ಮೆಡಿಕಲ್ ಕೋಮಾಬಿಡಿಟೀಸ್ ಇರೋದಿಲ್ಲ, ಬಿ ಪಿ, ಶುಗರ್ ಅಂತ ಎಲ್ಲನೂ, ಐಟು, ವೆಯ್ಟು, BMI ಅವೆಲ್ಲ ನಾವು ಟೇಕ್ ಇನ್ ಟು ಕನ್ಸಿಡ್ರೇಷನ್. ಓಕೆ, ಅದಾದಾದಮೇಲೆ ವಿ ಸಿ ಯರ್ ರಿಪ್ರೊಡಕ್ಟಿವ್ ಪ್ರೊಫೈಲ್ ಟು. ಗರ್ಭಚೀಲ ಹೆಂಗಿದೆ, ಗೆಡ್ಡೆ ಏನು ಇಲ್ವಾ, ಅವ್ರು ಬೇರೆ ಇನ್ನೇನು ಲೈಕ್ ಎಂಡೋಮೆಟ್ರಿಯೋಸಿಸ್, ಫೈಬ್ರಾಯ್ಡು ಅವೆಲ್ಲ ಏನು ಇಲ್ವಾ. ಫಸ್ಟ್ ಅದಾಗಬೇಕು ಅಂತಂದರೆ ಫಸ್ಟ್ ವಿ ಹ್ಯಾವ್ ಟು ಸಿ ದಟ್ ಶಿ ಹ್ಯಾಸ್ ಗಾಟ್ ಎ ಚೈಲ್ಡ್. ಓಕೆ, ಆ್ಯಂಡ್ ದೇ ಶುಡ್ ಬಿ ನಾಟ್ ಮೋರ್ ದೆನ್ 1 C-section, ಬಿಕಾಸ್ ಅವ್ರಿಗೆ ಸ್ವಲ್ಪ ಕಾಂಪ್ಲಿಕೇಶನ್ ಜಾಸ್ತಿ ಆಗುತ್ತೆ. It is not like that they go for this again time a C-section, but it is good for if they have got a normal deliveries. Okay, and if they have got a child. Then apart from this, we do all the medical screening, as I have told you. They are this one, lungs, everything, and the medical testing, and especially we are very much important in the 2 parts which we do. But in this country we won't see that much more, like smoking, drug abuse, recreational drugs. Where I was working abroad, yes, we had that, and we used to take into that, and we used to put the people to task to see that they are not behind that. Okay, and then apart from this, we used to see the screening, normal HIV, HPV, SHG, everything. And if they are good, then we recruit them. Before recruiting, it is very important to counsel them, because there are 2 types of approaches. The commissioning agents will be there. Okay, they will be telling, they will be taking care in the paying guest home, or they will be left at home. When they are at home, they should be instructed regarding the diet, regarding the work they do, and regarding the personal relationship with the husband. Everything should be, and it should be of voluntary, not by coercion or by exploitation. It should not be. So we take a group, we discuss with them, and is it of voluntary, and our psychological counseling is very much important. We study them. Then it is better to enroll them to the surrogate program, and it's very much important that their compliance is there. If there is a breach in the compliance, then it is very difficult to further go. For example, I'll give you an example here. Okay, I had a patient. Okay, she had become pregnant, she had conceived. See, we know that the couples are so desperate to have a baby, and she had become pregnant. Okay, she had a commissioning agent who was taking care. Okay, at 12th week, okay, because they receive monthly installment of the amount. Okay, 12th week, she didn't tell anyone. She took MTP pill packet. Understood? This by
But that legally, is that okay?
illegal again. Yake antandre she got 2 months amount now. Monthly they are paid. So nicely she took the tablet and she got aborted. And
But she can be punished for that.
Pardon?
Can she be punished according to
She
law?
didn't reveal. She told it is my national for me it is a threatened miscarriage. But by the history later we saw that she had taken a pill. Understood? It is so important, so delicate matter. So voluntary is important, not by by exploitation or by family. Dynamics play a very much low role, because the family members first for 1 month, 2 months they can take money and they can. So we have to track them, you know. So the family dynamics, the husband, everyone plays a critical role, and it is very difficult to manage them really. And if they go through all this track, it is really a boon.
Okay, doctor, what are the latest advancements in this technology? Success rate increase ಆಗಬೇಕಂದ್ರೆ ಏನೇನು advancements ಆಗಿದೆ ಡಾಕ್ಟರ್ ಈಗ?
ನಾನು ಆಗಲೇ ಹೇಳ್ದೆ, ಇದು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ಸ್ ಮಾಡಬೇಕಾದ್ರೆ ವಿ ಆರ್ ರೀಪ್ಲೇಸಿಂಗ್ ಮೈನ್ಲಿ ದಿ ಸರೋಗೆಸಿ ಮಾಡಬೇಕಾದ್ರೆ ವಿ ಆರ್ ರೀಪ್ಲೇಸಿಂಗ್ ದ ವುಮೆನ್ ಹೂ ಈಸ್ ಕೇಪಬಲ್ ಆಫ್ ಹ್ಯಾವಿಂಗ್ ಅ ಬೆಟರ್ ಇಂಪ್ಲಾಂಟೇಷನ್. I don't think illi ನಾವು advanced technology is going to really work it out. Simple technology will also work it out, because ಇಲ್ಲಿ ನಾವು ಎಲ್ಲ ರೀಪ್ಲೇಸ್ ಮಾಡ್ತಾ ಇದ್ದೀವಿ. This is not a infertile couple. ಡೋನರ್ ಎಗ್ ಪ್ರೋಗ್ರಾಮ್ನಲ್ಲಿ ವಿ ಟೇಕ್ ಎ ವಾಲಂಟರಿ ಡೋನರ್, criteria is fulfilled, good quality oocyte, good quality embryo can be prepared. Surrogacy-nalli ಹೋಗಬೇಕಾದ್ರೆ she is already delivered, she has already got a child and there is no problem with her. Because infertile couple is spending so much of time, so much of money, we are not supposed to take a surrogate who is aged, doesn't have a proper uterus, proper endometrium development, all those things. We have to screen. ಅವರು ಸೂಟಬಲ್ ಆದಾಗ ಮಾತ್ರ ಅದನ್ನು ನಾವು ಸೆಲೆಕ್ಟ್ ಮಾಡೋದ್ರಿಂದ ನಮಗೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗೋ ಚಾನ್ಸಸ್ಸು ಮೋರ್ ದೆನ್ 75 ಇರ್ತದೆ. ಅದರಲ್ಲಿ ನಾವು ಅಡ್ವಾನ್ಸ್ಡ್ ಟೆಕ್ನಾಲಜಿ ಯೂಸ್ ಮಾಡಿ ಒಳ್ಳೆ ಎಂಬ್ರಿಯೋ ಯೂಸ್ ಮಾಡಿದಾಗ ಡೆಫಿನೆಟ್ಲಿ ಪ್ರೆಗ್ನೆನ್ಸಿ ರೇಟ್ ಇದು. ಅಡ್ವಾನ್ಸ್ ಟೆಕ್ನಾಲಜಿ ಅಂತ ಹೇಳ್ಬೇಕಾದ್ರೆ ಒಂದು ಬ್ಲಾಸ್ಟೋಸಿಸ್ಟ್ ಕಲ್ಚರ್ ಅಂತ ಮಾಡ್ತೀವಿ, IMSI ಅಂತ ಮಾಡ್ತೀವಿ, ಅದರಲ್ಲಿ ಸ್ಪರ್ಮ್ ಯಾವುದು ಚೆನ್ನಾಗಿರ್ತದೆ, ಯಾವುದು ಪ್ರಾಬ್ಲಮ್ ಇಲ್ಲ ಅದನ್ನು ಸೆಲೆಕ್ಟ್ ಮಾಡ್ತೀವಿ. ಟೈಮ್ ಲ್ಯಾಬ್ಸ್ ವಿಡಿಯೋ ಮಾನಿಟ್ರಿಂಗ್ ಅಂತ ಇರ್ತದೆ. ಯಾವಾಗ ಅದು ಒಂದು ಸ್ಪರ್ಮ್ ಎಗ್ ಜೊತೆಗೆ ಸೇರಿ ಭ್ರೂಣ ಉತ್ಪತ್ತಿ ಆಗುತ್ತೆ ಅದನ್ನು ಕಂಟಿನ್ಯೂಸ್ ಮಾನಿಟ್ರ್ ಮಾಡ್ತಾ ಇರ್ತೀವಿ. ಅದು ಒಂದು ಹಂತದಿಂದ ಒಂದು ಹಂತದ ಹೇಗೆ ಡೆವಲಪ್ ಆಗ್ತದೆ ಮಾಡೋದ್ರಿಂದ ಇಲ್ಲಿ ಆರ್ಟಿಫಿಷಿಯಲ್ ಇಂಟೆಲಿಜೆನ್ಸು ಈಗ ಬರ್ತಾ ಇದೆ. ಬಂದಿರೋದ್ರಿಂದ ಈ ಒಂದು ತಂತ್ರದಿಂದ ನಾವು ವಿಲ್ ಬಿ ಏಬಲ್ ಟು ಸೆಲೆಕ್ಟ್ ಎ ಬೆಟರ್ ಕ್ವಾಲಿಟಿ ಎಂಬ್ರಿಯೋ. ಹೀಗಾಗಿ ಚಾನ್ಸಸ್ ಆಫ್ ಬಿಕಮಿಂಗ್ ಪ್ರೆಗ್ನೆನ್ಸಿ ಇಸ್ ಮೋರ್ ಇರ್ತದೆ. ಇದು ಇನ್ಫರ್ಟೈಲ್ ಕಪಲ್ನಲ್ಲಿ. ನಾವು ಥರ್ಡ್ ಪಾರ್ಟಿ ರಿಪ್ರೊಡಕ್ಷನ್ಗೆ ಹೋದಾಗ ಬಿಕಾಸ್ ವಿ ಆರ್ ರೀಪ್ಲೇಸಿಂಗ್ ದ ಎಗ್ ಆರ್ ಸ್ಪರ್ಮ್, ಈಸಿ ಚಾನ್ಸಸ್ ವಿಲ್ ಬಿ ದೇರ್. ಅಡ್ವಾನ್ಸ್ಡ್ ಟೆಕ್ನಾಲಜಿ ಇದ್ದಾಗ ಡೆಫಿನೆಟ್ಲಿ ಅಲ್ಲಿ ನಮಗೆ ಒಳ್ಳೆ ಪ್ರೆಗ್ನೆನ್ಸಿ ರೇಟ್ ಸಿಕ್ಕೋ ಚಾನ್ಸಸ್ ಇರುತ್ತೆ. ನಮ್ಮಲ್ಲಿ ನಾವು ಸರೋಗೆಸಿ ಮಾಡಿದ್ದೀವಿ, 1 ಅಥವಾ 2ನೇ ಸೈಕ್ನಲ್ಲಿ ಡೆಫಿನೆಟಾಗಿ ಅವರು ಪ್ರೆಗ್ನೆನ್ಸಿ ಆಗಲೇಬೇಕು. ಆಗಲಿಲ್ಲ ಅಂತಂದರೆ ನಮ್ಮ ಕ್ರೈಟೀರಿಯಾ ಏನು ಸೆಲೆಕ್ಟ್ ಮಾಡಿದ್ದೀವಿ ದಟ್ ಈಸ್ ನಾಟ್ ಅಪ್ ಟು ದ ಮಾರ್ಕ್ ಅಂತ.
75% ಸಕ್ಸಸ್ ರೇಟ್ ಇದೆ ಸರೋಗಸಿಯಲ್ಲಿ.
ಓಕೆ, ಸೊ ಫೈನಲ್ ಆಗಿ ಬ್ರೀಫ್ ಆಗಿ ಕ್ರಿಸ್ಪ್ ಆಗಿ ಏನು ಹೇಳಕ್ಕೆ ಇಷ್ಟಪಡ್ತೀರಾ ಸರೋಗಸಿ ಅಂಡರ್ಗೋ ಮಾಡ್ಕೋಬೇಕು ಅಂತಾರ ಕಪಲ್ಗೆ?
First, for the couple, I like to tell them, because they will be very happy to invite a new member to the family. But sometimes the path may not be so smooth. Though we select the surrogate, there can be ups and downs. For example, threatened miscarriage ಆಗ್ಬೋದು, ಅಥವಾ ಮಿಡ್ ಟ್ರೈಮಿಸ್ಟರ್ ಮಿಸ್ಕ್ಯಾರೇಜ್ ಆಗ್ಬೋದು, ಅಥವಾ ಏನಪ್ಪ ದ ಬೇಬಿ ಮದರ್ಗೆ ಪ್ರಾಬ್ಲಮ್ ಬರ್ಬೋದು, BP ಬರ್ಬೋದು, ಶುಗರ್ ಬರ್ಬೋದು, ಇಂಟೆನ್ಸಿವ್ ಕೇರ್, ಬೇಬಿ ನ್ಯೂನೇಟಲ್ ಕೇರ್ ಬೇಕಾಗ್ಬೋದು. ಇವೆಲ್ಲ ನೀವು ಫೇಸ್ ಮಾಡಬೇಕಾಗುತ್ತೆ ಅಂತ ಫಸ್ಟ್ ಕೊಡಬೇಕು. ಓಕೆ, ಅದಾದಾದ್ಮೇಲೆ ವಿ ಶುಡ್ ಬಿ ವೆರಿ ಟ್ರಾನ್ಸ್ಪರೆಂಟ್ ಆ್ಯಂಡ್ ದೇ ಶುಡ್ ಬಿ ಇನ್ ಅ ಪೊಸಿಷನ್ ಟು ಸಿ ದ ಡಾಕ್ಯುಮೆಂಟ್ಸ್, ಟು ಮೀಟ್ ದ surrogate, so that they will have the attachment of the baby. Understood? And they will be involved in the program. And they will be, psychologically they should be tuned to take up the baby soon after it is born. So this is the information which I need to give to the recipient. Okay. But for the donor, we need to give many things, because they are prone for ethical risk, legal risk, health risk, okay, and financial monetary benefits. So we have to counsel them regarding everything and how we protect them, so that we will put them into ease.
Okay, doctor, your final piece of advice?
Definitely third party reproduction is expensive. We can replace the sperm factor, which is not costlier. We can even replace the egg factor, it is bit costlier. When they go for surrogacy, monetary wise it is becoming expensive, because we say always altruistic. Practically no woman come forward and dedicate her life for another 9 months. She has got so many accomplishment, she has to fulfill all these things. This is a practical problem. But because it is exploited like anything, government is made it no commercial surrogacy at all, altruistic. But off the record it is done. I don't think if it is going to be continued like this, some other day these are the things is going to surface it. Because third party reproduction, we don't know. Patient after becoming the pregnant, she may disappear. Pregnancy is she may disappear. Though she has signed affidavit, everything, legal paper, everything. What you do it? Like Madam told, MTP she has undergone, because of commercial interest. So this is the big headache actually, we face it. But in this thing actually, poor people are the sufferer. Donor egg program, donor sperm program, and when they go to surrogacy, it is very difficult, next to impossible for them to undergo surrogacy. That's the reason why I think in future all these government medical colleges come up with a IVF center where they start doing the third party reproduction as well. And for those who are really required a third party reproduction is not going to be so expensive.
Okay, thank you so much, doctors, for
But
being on
I
the
want to
panel.
give a message. To prevent all this, early marriage is very important. Then to maintain fit. Okay?
Early marriage and early children
Early,
also.
yes. What in our olden days we were doing. 21 years, 20. But
Lifestyle
you
is
may not
changing,
have,
madam.
and they should keep fit and they have to plan. The women are dynamic, so women should be broad-minded and take up the family first. They can earn later.
Thank you so much, sir. Thank you so much for being on the panel.
So I had a legal advisor and they told no. Because
Actually,
a
not
woman
just you,
can
doctor.
have
Many
a
of
child,
them are
but
not
she may leave
aware
it
of the
later.
rules and
She
regulations.
may leave the father-in-law and the mother-in-law and go only for the property she can have the child. So they told no, it is not allowed.
No,
Okay.
madam. Brain dead, it is not declared. Wife can avail it because she is legitimately married. What is property, what is going
this is
to
the one
happen,
which
it's
is
okay.
still,
And
the guidelines are not proper now.
single woman, even if she doesn't use her own married husband sample also, she has a right to use some other sample, second option. And as a male, I cannot use somebody's egg. In rule, it is not allowed. Single woman, it is allowed.
Yeah.
It is in the rule.
If the husband gives a consent, she can have. If she is married, if it is a single, okay? But if it is not, it comes as adultery. So these laws are still not well formed, so that it needs further depth to go into this one. To study
actually-
is very important. Then to maintain fit. Okay?
Early marriage and early children
Early,
also.
yes. What in our olden days we were doing. 21 years, 20. But
Lifestyle
may
is
not
changing,
have,
madam.
and they should keep fit and they have to plan. The women are dynamic, so women should be broad-minded and take up the family first. They can earn later.
Thank you so much, sir. Thank you so much for being on the panel.
Thank you, everybody.
Wow. Thank you so much, Dr. M.S. Srinivas and Dr. Bharati Rajanna, for navigating these complex topics with such clarity. Can we all give them a huge round of applause for delivering such an informative panel discussion? And special thanks to Archana ma'am for driving this so well. Innonsati ಜೋರಾದ ಚಪ್ಪಾಳೆ ಬರ್ತಾ ಇರಲಿ. I request Urvi Mehta, Senior Vice President, Brand First, to kindly come forward to give away mementos to our panelists and moderator. Thank you so much, ma'am. Thank you so much, sir. Let's all stay together for a group picture. Here at the Path to Parenthood event, we've been learning a lot about how to embrace parenthood the right way when you're facing challenges. And we also learned about Hoopsters, a hybrid non-academic education platform that has a community that provides the right resources, curated programs, and continued engagement to help achieve this goal. Primarily, they focus on mental health, parenting, life skills, and sustainability. Well, we have somebody now who is coming forward to share with us her personal story. Deepika Murthy is a passionate advocate for adoption, and she herself is an adopter, a healer, wellness facilitator, a psychodramatist. She understands emotional well-being and clarity so perfectly. She is here to share with us her personal story. Deepika, the stage is all yours.
Thank you so much, Privil. Thank you, audience, for being here, taking time out on a Sunday for such a beautiful event. When Bala, our Hoopster team boss, we call him, when he told me about this event happening and if I would love to share my story as an adoptive parent here, it kind of brought back a lot of memories. Memories not just of, the technical process of adoption, but I think an emotional journey. And I'm right here to share a dream. But before I share, I would love to at least see you people raising your hand. How many of you have dreamt of something like in your sleep, the real dream? And then it just came true. You never expected that it'll happen, but it did. Can you raise your hands if it has ever happened? Oh, lovely. How about the group here? Yes, sometimes we don't even remember our dreams, but yes, very often some things just happen and we recall, oh yeah, I did dream about this. I want to start my story with this beautiful dream I had. This is back in 2009. I started having this very vivid dream. It's going to be a little graphic, quite weird, but you'll know why I dreamt. So now I am there, there's a table in front of me, just like you have a table right there. And I'm standing there, there's a table there, and something is happening, something very physiological is happening there, as if there's a surgeon there and, cutting open somebody's womb and bringing a baby out. And it was visible. And he took that baby out from an apparent womb which is out of the body, kept on a table, and he hands that little fetus in my hands. Okay, now this was very graphic and very disturbing initially when I woke up from my dream, but it didn't leave me. It's like, the more you run away from something, it follows you, and that's what happened with me. And this dream kept coming to me recurrently for almost 5-6 years. Fast forward to 2014. October 2014 is when I registered with Kara, my husband and I, because we always wanted to adopt. We had a biological son. He was already 3 years old. And because we always wanted to adopt, we decided, nahi, bas ab to karna hai, bhai. And we did that. And the moment I registered, that dream stopped. And that is what had happened. Something that was coming to me so fervently in my dreams finally came out in reality. And I think it's one of the rarest dreams that came true for me. The rest of them have died a natural death. But yes, this one stayed. Fast forwarding again to 1 year, 2015 is when, if you all are aware, there are a lot of adoption rules that changed. Menka Gandhi brought in, I would say, some very practical rules of adoption where, you know, you can't really choose an agency anymore, because most of the times that would happen. You choose an agency and then you go and get your baby home and you do a selection procedure, etc. But things change. So now you have like a username, password, you have like a login ID, very professional. And then you log in and you'll know after registration, where do you fall in that entire list, the waiting list. Now these rules changed, and we had already registered in 2014 with an agency, and then suddenly it was like, nay, not this agency, something else is going to happen. Now you just have to choose your state, and if there are babies available, we will propose the babies to you. This part was a little unnerving, because it was like as if we are doing some Amazon shopping, putting the babies in cart and then choosing later what we do. But then probably it was for the bigger picture, the bigger good, because that process ensured that all babies get a chance of being adopted, which otherwise was not happening, because there were so many agencies which parents would not deliberately choose, and which left so many children parentless and parents childrenless. So I was kind of happy, and then whoosh, within a month is when I brought my daughter home. She's Asavari. I named her Asavari because the name of a beautiful rag. And my son Arav, who was 3 years old, 4 years old when his sister came. And I think that was the most beautiful part. It's not just about being an adoptive parent, but also being a parent of a child who is seeing adoption happen, who is seeing a sister coming home, not out of his mother's womb, but a sister who is just handed over to his mother. And he was the first one, even before my husband held his baby, my son held his sister in his arms. He was there throughout the process. It was an arduous process, I agree. Emotionally very draining, because you have to keep waiting, but it was worth the wait. And it was 2015 when my daughter came home. 9 years today, everything is still so fresh. But at the same time, one thing that I always felt, and I would share, is I never felt anything different. Now, you know, we, unfortunately in our society, adoption is labeled as charity, or, oh wow, you're doing great. Oh, you're doing such a great thing that you're adopting a child. No, that's absolute rubbish. You know, love is what comes out from within. It should not put you on a pedestal. It should ground you. If you're ready to give and receive love, you should be ready to break your ego, break down yourself into a million pieces and renew yourself into a new human being. You cannot accept love if you feel that you're doing a favor by giving love to somebody. And I think that is where the whole mindset has to shift. It has shifted, certainly. It's very different now. The very fact that we are having a talk about it means that there has been a great shift over the past years. Otherwise, it was like, hush, don't tell. The children didn't know. The children anyway were never told. And, you know, even family members, no, you can't tell your family members that we have adopted a baby, you know. So, normalizing something, normalizing parenting, I would say. What is adoption? It is another route of parenting. Why are we attaching so many labels to it? We are choosing. Are we choosing? How many of you feel that you choose to adopt? How many of you feel? Raise your hand, like honestly, that you choose to adopt. Sorry to break your bubble, but you don't. Because I very honestly feel we don't choose. The children have chosen us. We are chosen. And that is why we were there. That is why something changed in us. So when we say adoption changed me, no, my dear. The transformation had already happened in you. That's why the change had already been, the seed of change already sprouted in you, which is why you were there, ready to accept your child. So saying that, oh, this child is my adopted child, would you say, would you label your child which has come out of your womb at, oh, meet my biological child? We don't say that, right? Meet my biological child. This is my womb child. We don't say that. So child is a child. That's my daughter, that's my son. If you are ready to remove all those adjectives, labels from your own ego self, that, oh, I'm doing this, and you know, this child is this, from yourself and from your child, oh yeah, you're ready for parenting. And I think it's not just about adoptive parents, it's about parenting itself. You know, when you become parents, you don't attach so many labels to it, so many adjectives to it. Do you say, oh, you know, I am an average parent, or you know, I am a biological parent. You don't attach adjectives, then why to adoption? And therefore, the question comes to, are you really ready? And why are you adopting? The intent. I do agree, most of the decisions, most of the alternate routes of parenting are chosen because 90% of the times it starts with a desperation. That yes, you want to become a parent. And because natural way is not working, or probably the IVFs have failed, maybe surrogacy is not on your list or not acceptable, okay, then shall we adopt? So somewhere, adoption has become like the last option. अरे कुछ नहीं हो रहा है तो चलो adopt कर लेते हैं. And this is where we commit a mistake. Don't do it. I always tell parents, if you're doing it because you're so desperate to become a parent, please don't do it. Because it is going to reflect. It is going to reflect on parenting. You'll always keep telling yourself that, अरे मैंने किया क्योंकि मुझे करना था. Like, sorry, I'm just using some sprinkles of Hindi if you're okay. And that is where there's a lot of self-questioning, self-introspection, which is required when you decide to adopt. For me, I always wanted to adopt, but then, I mean, back then, yeah, younger days and more vulnerable and more impressionable. Then the parents, you know, my parents were like, nahi, nahi, you know, do it, why don't you try natural way and all that. So it was a bad phase for me where I somehow felt pressured into having a child naturally, although no regrets today. But even then, there was this thing, let me adopt twins. And, but, you know, under the pressure, okay, chalo, we'll have, our baby. And that's when my son, Arav, happened. But then, after that, it was like very, very clear, ki nahi, nahi, nahi. Now, it's like I'm telling my parents, now enough, huh? Now don't ask me for another one. Okay, just keep shut and let me do what I want to. And that is when all of this happened. And I would definitely also want to share a very personal incident. It's personal, it's very, very intimate. Nevertheless, I think this is the right platform to share. When my daughter was about to come home, I was prepping for her. I was very keen to breastfeed her. And everybody was like, no. How can you breastfeed, you know, your child whom you're adopting? Your body is not ready. You're biologically not ready to breastfeed a child. Trust me, 100%, including my husband. Okay, this is a bad idea. I mean, really, I mean, what all do you dream of? What's wrong with you, woman? I said, ye to karna hai. I was very keen because I am also a great advocate of breastfeeding. And she came home. I tried, so I wanted to go to the doctor. The gynecologist gave me Shatavari and this and that, and many things happened. I was not able to take any of those medications because that's what the doctor said. You take this. We are hoping that it is going to, induce some milk production. And I couldn't do it because we were running around with paperwork. And then Asavari came home on 9th September. 10th September onwards, I decided whatever it is, I will have to do it. And I did it. It took me 4 days, that's it. And I think 5th day, when I started breastfeeding my girl, everyone was like, are you sure? No, are you hallucinating? Drugs liya hai kya? Ye kaise ho sakta hai? You didn't take any medication. How can that be possible? Well, why not? People do all kinds of things in love. Why can't love produce nice hormones in your body? The first relationship of a mother with a child, the personal, the contact is here. This is where love comes from. So why can't I? If there is love, oh hell yes, there is milk. And I think that is one day where I reassured myself, hey, this is something else. I didn't choose Asavari. She chose me. She chose me to be her mother. I am privileged. She did not get a home. I got a child. The second label that we need to remove is that we are giving a child a home. No. Yes, a child is getting a parent. But more than that, you are receiving that. You receive love and you'll be so full of it that it'll be so much easier. Love will flow out of you. And I think one of the many really miraculous and magical experiences I've had in my adoption journey. I mean, I can sit here and talk till cows come home, but I'm not going to do that. But this is, I think, top of the list. And after that, of course, life, okay, can I say life has been, oh wow, great, Asavari came? Nahin. Life has been what life is. I have 2 children, I am running around like a headless chicken, and I have my own share of problems. So, कुछ नहीं होता है दिमाग में कि adopt किया है या I have produced from my womb, doesn't matter. At the end of the day, it's all. But at the same time, if I find myself, there's a lot of self-work. There is a lot of emotional work and self-work which is involved in this whole process, where I have to make sure I don't treat any of them better or worse. What happens is many times parents try to be nicer to the child they have adopted, thinking, arey, no, they will feel the difference. Trust me, they will feel the difference if you try to treat them better. They will feel, arey, why is she being so nice to me? And tomorrow, later on, now since, it is recommended that let the child know where the child has come from. It's good, it's healthy. It's better that it comes from the parent and not from dadi, nani and friends and family members. Because yes, we have to be ready. There will be a moment of identity crisis that the child is going to feel once the child comes to know. But if you are, the child has to feel that you're right next to him or her. That, first of all, I know it. There is awareness. And secondly, I don't have to second guess anything because there's so much of love. So that boils down to the point, again, to the third label of, or the, I would say, the misconception of hiding things from your child. Make it a normal process. Be with the child. And this is what, every day we are trying to do. That's the least we can do. Stand by your child. Stand by what the child gives you and what you give the child. And being a Krishna, uh, the responsibility lies even greater on me. That I make sure that my children, and before my children, I am emotionally and mentally sorted enough to make wise, informed decisions when I am parenting. Adoption is just another route of parenting, and that's all we need to know. It's not fashionable, it's not something great, it's not charitable, it doesn't make you a great human being. No, it makes you as normal, as helpless a human being as anybody else, as probably another parent who's been trying to have a child through either natural ways or IVF or anything. And this is where I would like to share a small poem I wrote a couple of years back, 4 lines. A bond beyond the bones, across the flesh and atoms apart. For only in biology books do cords connect the navel. In love, they connect only the hearts. Thank you very much. I'm Deepika Murthy, a parent, normal, running parent of 2 children. Thank you. If anybody has any questions, anything at all, I am right here. Please feel free. Thank you.
Deepika, a post-lunch session. Everybody is attentive. I'm sure the folks listening to us on YouTube as well, they were attentively listening to you. Thanks for sharing your story. Ladies and gentlemen, a huge round of applause once again. Adoption doesn't change you. That's what Deepika said. Instead, you are drawn to adoption because a transformation has already begun within you. Thank you so much once again, Deepika. And I now request Mr. Ashutosh Dwivedi, CEO of Vyli Health, to kindly come forward to give a memento, a token of appreciation to Deepika. Can we all give a huge round of applause? Path to Parenthood 2024, an initiative by NewsFirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, knowledge partner Vyli Health. Well, we have reached to the last segment of the day. We are going to have a panel discussion, but I want all of you to let your friends, family members, colleagues, your friends and people whom you meet day in and day out to watch, follow the content which has streamed live on NewsFirst. So you can search and find us on YouTube as well. Now, we dive into PCOS, PCOD, weight management for natural or assisted pregnancy success. Our panelists for this session are Dr. Madhuri Patil, fertility expert and Vice President ISAR. Can we all give a huge round of applause and welcome Dr. Madhuri Patil onto the stage, please? Ms. Swati NG, nutritionist, a warm welcome to you, ma'am. And to moderate this session, I kindly request Mrs. Archana Ravikumar, senior journalist, a warm welcome to you as well, ma'am.
Good afternoon, all of you. I think after a heavy lunch, we'll be now talking about weight management and obesity. I don't know how much that will help. Doctor, actually, as we know, any girl we talk to, 90% of them, they have this PCOD or PCOS problems. And definitely that affects fertility. What is your take on that?
I would like to say that today PCOS is overdiagnosed, and it's very important that we do not diagnose PCOS in an adolescent. We need to wait for at least 8 years post-menarche or till she is 18 years. So if you find that the features of PCOS are there in the adolescent girl, we have to label her at risk and then come to a final diagnosis only when she's 8 years post-menarche or she's 18 years. This is because there are certain features of PCOS which are present in an adolescent, which is physiological. Like a girl who's just got her menarche also will have acne, so that's one of the features. And the other feature of PCOS basically where we say that she has polycystic ovarian morphology. So that is normal physiological in an adolescent girl. And therefore, most of the diagnosis happens wherein the patient comes with obesity, because nowadays, because of the fad diets as well as eating outside and the lifestyle, obesity is very common right in the children as well as when they become adolescents. And so what happens basically is that because of that also they have irregular cycles, and usually in the first 2 to 3 years of normal puberty you have irregular cycles, and it takes that much time. So we should not label any adolescent as PCOS till she reaches reproductive maturity, because there are certain features which resemble PCOS are present normally.
Okay. Ms. Swati, are there any specific diet strategies for people suffering from PCOS or PCOD?
Yes, there are definitely diets that can help to manage PCOS and sometimes even reverse. So to an extent, first thing, it should be a realistic diet plan which can be followed over a long period of time, because PCOD or PCOS is not something just that comes and goes. So it's a management. So basically it would be a lifestyle change, the difference in the way of eating. Second would be physical activity, as doctor was also mentioning. Being active is a very important part. Maintaining your weight, because for most of them who lose weight, maintaining that weight is also very difficult. So the follow-up diet that we give should be more doable. And then of course certain supplements can definitely help. Even the doctors do suggest, as well as we do.
Doctor, actually early detection of PCOS or early weight management, how does that help with fertility and PCOS?
So usually obesity is seen in about 60% of the women who have PCOS. 40% of them are lean PCOS. Though they are lean, basically they also have visceral obesity, because most of especially the Asian population, they are sarcopenic. That is, they have less muscle mass and more fat, and it's basically the visceral obesity. So though it's a lean PCOS, they do have visceral obesity or central obesity, and that's basically related to hyperandrogenism, because we need to know that PCOS is a combination of hyperandrogenism. So when we diagnose, if we see any clinical features, especially hirsutism, more than acne or female pattern of balding, or any other signs of hyperandrogenism, then they should have irregular cycles. So if these two are present, we directly diagnose them as having PCOS. But in case she has only menstrual irregularity and she does not have any clinical features like hirsutism or acne, then we probably do blood test wherein we look at the androgen levels. And if both are there, then we diagnose them as PCOS. But only if either of them is there, then only we require today an ultrasound where we have a polycystic ovarian morphology for diagnosis of PCOS. So basically what happens is that we really don't know whether it is obesity which results in PCOS or PCOS which results in obesity. That's still very debatable because we have evidence for both of them. But it is usually seen that usually the hormonal imbalance which is seen in women with PCOS is exaggerated in the presence of obesity, and therefore the clinical symptoms also get exaggerated. Plus, obesity is associated with insulin resistance and hyperinsulinemia, which are then the main cause of anovulation and several other metabolic dysfunction. Though insulin resistance and hyperinsulinemia is not included in the definition of PCOS, it is one of the main criteria later on which results in infertility as well as in metabolic dysfunction.
Ms. Swati, today both micro and macronutrients are posing a problem. So how important is it to balance both of them?
Yes, macronutrients, not just counting carbohydrates, proteins and fats. When it comes to micro, especially in terms of PCOS or if you're trying to get pregnant, is a very important aspect. So coming to the research, as we have come so many years researching about PCOS, a low carbohydrate diet, or even if we go to keto, that is what we recommend currently for managing PCOS, and along with that a few supplements that we want them to take, so that, as ma'am was also saying, there would be certain features which is showing up and may not necessarily be PCOS altogether. So to manage that as well, like ma'am was saying about acne. So chromium is a great agent to help with acne reduction. So such things can be added into their diet via food.
Okay. Doctor, sometimes just lifestyle changes will not help. Like some treatments like ovarian drilling and ovulation induction therapies are also there. Can you elaborate on them?
The treatment basically in a patient who has infertility will depend on several factors apart from having PCOS. One is age of the patient. So if the age of the patient is more than 35 or 36 years, it's best to go on with the treatment for infertility straight away and not wait for lifestyle interventions. Duration of fertility, if it is more than 3 years, plus if there is presence of any other infertility factors, like if the patient has associated endometriosis, she has associated adenomyosis, fibroid uterus, or she has infection because of which she has blocked tubes, and there is a male factor, then basically we should not wait for lifestyle. If she is less than 30 years, yes, we should surely give her at least 3 to 6 months for reducing her weight, because that might result in a spontaneous pregnancy also, or it might decrease the amount of drugs we give and also improve the success with the treatment what we are offering. And the best drug, the drug what we use is, we start with the oral ovulagens, and what we use today is letrozole, and it is normally given for 5 days from day 3 of the cycle till day 7, and then the monitoring of the follicular growth is very, very important, because it does not make sense when you're taking the tablet and you tell the patient, oh, you have sex on alternate days, because many a times they do not respond. So we have to know whether they respond to the drug or not. So that's very, very important. So from the 9th day onwards, I think doing follicular monitoring either daily or on alternate days is important. Once the follicle is about 15 to 16 millimeters, probably you need to do it more regularly, because the follicle can rupture at any time. Because once the egg is released, basically, though it is alive for 24 hours, it's fertilizable only for about 12 hours, and therefore knowing the exact time is important. If she is resistant to letrozole or she does not conceive with letrozole, then one can go for clomiphene citrate. But with clomiphene citrate, the disadvantage is that many a times, because of its anti-estrogenic effects, it results in a thin endometrial lining. So in these cases, probably tamoxifen, which is also a estrogen receptor agonist, can be used. If the patient fails to conceive with either the oral, either clomiphene, letrozole, or with tamoxifen, then we need to go for gonadotrophins. Though initially ovarian drilling was considered as a second line of treatment, all the recent evidences are against doing ovarian drilling, because it has been seen that many a times ovarian drilling causes loss of follicles, and then the patients have premature menopause, and it can also result in adhesions if it's not done properly, and this can then prevent a natural conception, and then you have to go for basically for ART.
Ms. Swati, sometimes it happens that, from what I've heard, people with PCOS and all have these cravings for eating things. Is that true? And if yes, then how do you actually manage them?
Yes, they do have a lot of emotional eating, or I would say binge eating. So this is mainly to do with what ma'am was saying, hyperinsulinemia. So this just doesn't mess up your insulin, but also messes up your brain. So it almost shuts down your cortex, which is the main area where you will be able to make logical judgments. So this is a calling towards food when you're really not hungry. So you just satisfy your other feelings through food. So one way to overcome this situation would be have lot of variety. So the more variety available in food makes them more available for options they can snack on. Second, the options should be healthy. Mindful eating, that is what we say. And the third would be portion control.
Doctor, how does weight actually influence miscarriage and infertility? What are the complications generally for obese people?
Yeah. So basically, we can divide the effects of weight into several categories. One is it affects the hormones, so whatever hormonal abnormalities there, it is enhanced by obesity, like the insulin resistance is increased, the insulinemia, there's hyperinsulinemia is increased, the hypoandrogenemia is increased, and basically directly it can also affect the ovulation. Second is when we are treating the patient, obesity increases the amount of drug which is required. It can extend the time of ovulation, that the number of days required for ovulation. Plus, in a patient who is not taking treatment but is ovulating, like you have 4 phenotypes. So there is an ovulatory phenotype also, wherein the patient ovulates. That is the phenotype C, which is there. So these patients are ovulatory, but then it can delay the conception in this group of patients. Once pregnant, it increases the chances of miscarriage, and this is basically related to hypoandrogenism as well as hyperinsulinemia. And along with that, it has been seen that those patients who have basically high AMH values and who have an abnormal glucose hemostasis in the blood, hyperhomocystinemia, which is also seen in patients who have PCOS along with vitamin D deficiency. This increases the chances of preterm delivery, of miscarriage. Then there's also an increased chance of preterm delivery which is seen, and usually pregnancy associated complications like pregnancy induced or hypertensive disorders of pregnancy and gestational diabetes has a higher incidence.
Okay, Ms. Swati, about nutrition. Now, when a couple is undergoing fertility treatments, how much does diet influence and what is the success rate you have seen?
So weight loss, as ma'am rightly said, is a very important aspect, and even a 5% weight loss can account to a lot of fertility betterment, or I would say the quality of the embryo is better and her chances of ovulation also increases. So maintaining a healthy weight and having a gradual weight loss is very important. And definitely people who are trying to conceive, even naturally as well as assisted, should definitely opt for weight loss if they are in the overweight or the obese category. Otherwise, should at least adopt to a healthy lifestyle.
And doctor, what are the latest technology available to treat PCOS?
Pardon, I didn't get.
Latest emerging treatments and technology to treat PCOS.
So basically, there's nothing new which is there in ovulation induction. So it's basically use of the oral ovulants which we were using for so many years. When we talk about the gonadotrophins, we can use, though we have recombinant gonadotrophins now, but it has been shown with several RCTs as well as the Cochrane report has shown that there is no difference in the pregnancy rates as well as ovulation rates, whether you use a recombinant gonadotrophins or you use urinary or ultra pure gonadotrophins. There's a new concept now which has developed that talks about the gut dysbiosis. It's said that PCOS is associated with gut dysbiosis, and therefore probably treating these patients with prebiotics and with probiotics may be helpful. and more so in obese patients because obesity definitely alters the gut microbiome. Then coming to the insulin sensitizers, basically what we are using year long for more than 100 years is metformin, and it is supposed to be very effective, though it has some gastrointestinal side effects. But in some patients who cannot tolerate metformin, probably inositols can be used, but the evidence for using inositols is not much, and basically it is a nutraceutical and it's present in the normal diet what we are having. But now we are having the GLP-1 analogs which have come into the market. In India, they've just come recently, and they include the liraglutide and the semaglutide. The liraglutide is basically injectable, but the semaglutide is an oral preparation. And this helps in reducing the insulin resistance, as well as it also helps in weight reduction. So it is more effective in reducing the weight as compared to metformin when the GLP-1 analogs are taken.
Okay. So metformin is something which is widely accepted for fertility treatments. Metformin is widely accepted for fertility treatments.
Metformin itself does not cause ovulation. Basically, when you add to oral ovulants, like if the patient has not ovulated just by giving clomiphene or letrozole and you add metformin to it, it has been seen because it reduces the insulin resistance, it increases the glucose uptake in the muscle, so the glucose hemostasis is achieved. And basically, it also has its effect on the liver, where it increases the sex hormone binding globulin, because if it is reduced, the free testosterone or the androgens are more, and the estrogens also are more, and this can affect the ovulation as well as the growth of the follicle. So it increases the SHBs in the liver, and therefore the free testosterone and the free androgens also reduce, and therefore it improves the ovulation rate.
Okay. Ms. Swati, you were mentioning about supplements. Can you precisely tell us what are the supplements to be given to PCOS people?
Sure. So mainly we concentrate on few of them. The first one would definitely be vitamin D, because research has shown that severe vitamin D deficiency is mainly associated with insulin resistance and also increased risk of cardiovascular disorders and decrease in the production of healthy eggs. And the second supplement that we would definitely recommend is omega-3 fatty acids. As we know, it's an essential fat, and essential fats are very, very good for improving the health of the embryo as well as proper ovulation. It also flushes out the bad cholesterol, keeps you healthy, keeps you active. Then third definitely is folate. So folate, as doctors also prescribe it pre-pregnancy. So this also improves the quality of embryo, and to an extent it also improves your insulin sensitivity. And there are definitely other small ones, like I was talking about chromium and inositols. These are also recommended, and to an extent even cinnamon extract.
I think folate is advised immediately when they plan for conception itself.
Yes.
Doctor,
So
what?
basically, when we are talking about the nutraceuticals, I would like to add that probably CoQ10, which is an antioxidant, helps in women with PCOS, because usually these women have the oocytes because of the abnormality in the hormones, have a lot of mitochondrial dysfunction. And this mitochondrial dysfunction then can affect the fertilization rate as well as the embryo formation rate. And therefore, giving CoQ10 in this group of patients would really help them in conceiving.
So doctor, what is insulin resistance in PCOS, and how does it come in the way of natural conception?
So basically, what happens in PCOS is that there is a insulin receptor dysfunction, and this then is seen in the pancreas. This results in increase in the secretion of insulin. This secreted insulin has different effects on different organs in the body. So in the liver, basically it reduces the sex hormone binding globulin, and therefore there is increase in the androgen levels. It also acts on the adrenal gland, where it increases the DHES, and it also acts on the ovaries itself. So in the ovaries you have the egg, you have the granulosa cell which covers it, and then you have the theca cells. So it is the theca cells which produce the male hormones or the androgens. So what does insulin do is it increases the production of androgens over there, and it decreases the ability of the granulosa cells, because this androgen which is produced in the theca cells goes into the granulosa cells, and here it is aromatized into the female hormone or estrogens. So it prevents the aromatization of the hormone because there is reduction in the P450 alpha 17 alpha enzymes which are there, and therefore it again increases the androgen levels. And therefore as it is, the PCOS women have high androgen levels, and this hyperinsulinemia in turn increases the androgen levels. Moreover, in the muscle, it decreases the uptake of the glucose, and therefore what happens, there is impaired glucose tolerance, or there is also basically diabetes mellitus, and in the adipose tissue it increases lipolysis with dyslipidemia. Moreover, it also has action on the follicles. So in the follicles, because of the high androgen levels, it inhibits the meiotic changes, because all the eggs are basically arrested in 46 chromosomes, and if they have to be fertilized, they have to there has to be a reduction division to 23, which does not happen. And as it is, obesity which is there and is one of the main features of hyperinsulinemia and insulin resistance, basically results in inflammatory changes, and therefore the endometrial receptivity or the acceptance of the endometrium to the embryo is also affected.
Ms. Swati, there are so many popular diets like intermittent fasting and many other diets. Do they actually work for PCOS?
Yes, but to an extent, how much would you be able to follow? As I was saying earlier, there is ketogenic diet, there's even intermittent fasting. So intermittent fasting is actually not a type of diet, it's a way of eating. So when you follow it, if your adherence is 100%, then definitely you will be able to see the results. But mainly for PCOS, I would say intermittent fasting is a great way of eating, because you're eating according to your circadian rhythm, where your insulin is high or where the production is good, that time you're eating mostly, and where your insulin needs rest or keep up its sensitivity, that is during the night, you're not eating.
Doctor, what is your final piece of advice to our audience watching you? Your final piece of advice to the audience who are watching you?
Yeah, so basically one must know that there's an intrauterine origin of PCOS, and this is related basically to a lifestyle, and because of obesity or an altered lifestyle, or if the mother herself is having PCOS, or she smokes or she drinks, there is abnormal environment in the uterus, and this then results in several affections of the fetus, wherein there could be miscarriage, there could be decreased growth of the child, and they also could be epigenetic and genetic abnormalities. This decreased growth of the child is called as the thrifty phenomena, and when the child is born, it starts getting abundant food, and because of that they put on weight, and this then results either in early menarche, or it can result in menstrual irregularities, it can result in obesity, and today we know that obesity has become a pandemic all over the world, and I think it's because of our lifestyle. And I think most important, I feel, is that we have to improve our lifestyle. We should not eat much outside, because when we eat outside, we cannot control what we are eating, and therefore healthy eating is very, very important. And once they reach their menarche, again, we have to look at their weight gain, and also we have to look at their mental health. That is very, very important, because it has been seen that if you have there's a lot of competition, and there's a lot of stress, there's a lot of anxiety. This in turn then alters the hormonal imbalance, and this can trip your balance, and you can still become, develop symptoms of PCOS. Moreover, now we've seen there's a lot of, sexual, pre-promiscuity which is there, and because of that, the girls have started taking oral contraceptives. This again can affect your hormonal imbalance, and that can also, lead towards your PCOS. When you come to your reproductive life, It's again weight control, lifestyle, and it's best to conceive earlier. And if not possible, because today, because of their education, because of their work, they might not be able to want to conceive early. So then we still have the option of going for social egg freezing. So your eggs are basically of younger age, and whenever you want, till the age of 40 or 45, because in India we cannot do IVF for a patient who is more than 45 years of age is one of the options which is there. But I think lifestyle is the most important, and in this, apart from your diet and exercise, sleep is very, very important. Reducing stress is important, as well as avoiding smoking as well as alcohol, because I think that's become very common.
Ms. Swati, would you like to tell anything to the couple who are looking at weight loss?
Sure. So the main thing here is knowing your food. So knowing what can cause the insulin surge. So if you know the foods that can have controlled surge of insulin and still get your energy from that, so that could help. Giving a diet plan which is very easy for them to follow, and they would keep it consistent. Third, when you go out, especially as ma'am was also mentioning, don't resort to junk food. Eat mindfully. Choose the snacks very wisely. And fourth, definitely lifestyle. Keep yourself active, exercise, or at least do any physical activity that keeps you happy, because happiness is something which goes against the cortisol.
I think an anti-inflammatory diet is very, very important. And I would also, my last message would be that PCOS starts in utero, and therefore the mother-to-be has to take care, then she has to take care as a child, and the child, when it becomes big, also needs to take care. So this is a very important message, I think, which we need to know. And it is the male siblings also have PCOS. There's something called as male PCOS, wherein it has been seen that the male siblings and the male relatives of the female PCOS are having a higher incidence of metabolic disorders like diabetes mellitus. They have increased incidence of hypertension and cardiovascular disease.
So consistency is the key for weight management, I would say.
Yeah, I mean, weight management definitely reduces the incidence of cardiovascular events, and also it keeps your diabetes and hypertension under control. So as I said, lifestyle modification is the most important thing when we talk about PCOS, and one must remember that's only not in the female, but it's also in the male.
Thank you so much for being on the panel.
Thank you.
Thank you, doctors.
Thank you.
Ms. Swati, Dr. Madhuri, and Mrs. Archana Ravikumar, thank you for those practical and valuable insights on the importance of weight management in fertility. Can we all give a huge round of applause for the panel, ladies and gentlemen? I kindly request Mr. Maruti S.H., Editor-in-Chief, NewsFirst, to kindly come forward to give away mementos to the guests. Let's all join for a group picture. Dear friends, since yesterday morning, we had a 2-day Path to Parenthood 2024 event, wherein a lot of you turned up here, and we also had viewers engaged on YouTube. Thank you so much for being so participative and making this event a memorable one. I also want to thank our Honorable Minister Shri Dinesh Gundu Rao, Minister of Health and Family Welfare, Government of Karnataka, for inaugurating this event. I am also grateful to our organizers, team Path to Parenthood 2024, initiative by NewsFirst, co-sponsored by Garbhagudi IVF Center, supported by the Ministry of Health and Family Welfare, Government of Karnataka, organized by Brand First, knowledge partner Vyli Health, all the exhibitors, healthcare professionals, media professionals, participants, and thanks one and all for making this a memorable one for all of us. I now kindly request the organizers to kindly come upon to the stage. First and foremost, I request the team NewsFirst, Ravi Kumar sir and Maruti S.H. sir to kindly come onto the stage. Can we all welcome them onto the dais, please? Also, team Vyli Health, Vijay Gopal, Ashutosh Dwivedi and Pooja, I request you all to come onto the stage. Team Brand First, Urvi Mehta ma'am, Neeraj, Sheetal, Raghavendra. I request all of you to please join us here on stage. I also request Sriram sir to kindly join us here on the stage, please. Let's all join together for a group picture. I also request the extended teams of the organizers and exhibitors to be ready. We'll quickly capture a group picture. Yeah. Go in the center of the stage. Live stop, Madi. Can we all give a huge round of applause for the team of organizers? I request all of you to kindly join us here on stage, all the participants, the folks behind the screen, the entire team of NewsFirst. Yes, quickly join us here on stage. Our volunteers. Okay, the photographer is trying so much, but none of you are reacting. So when I say 1, 2, 3, everybody please smile, okay? At least smile. I know all of us are tired. 1, 2, 3, smile. Okay, this is the last picture. When I say 1, 2, 3, all of you thumbs up and in the front and say, 1, 2, 3. Shout out, everybody. I know there's no energy, but that's all right. Because you're the folks who work behind the scenes. And thank you so much, guys. Means a lot. I also request the extended teams of the organizers and exhibitors to be ready. We'll quickly capture a group picture